Good morning, everyone, and welcome to the School of Public Health Research Showcase Symposium for 2021, and welcome to the people who are watching us stream live online. My name's Caroline Miller and I'm the Chair of the School Research Committee, so I'll be emceeing today. So we've got a fantastic lineup for you today of speakers, accomplished speakers from the School of Public Health showcasing our research. It's been a tough year for research, a tough year for teaching. Well, tough 2 years really, but we've got some fabulous work and outputs to share with you today. So first I'd like to acknowledge the country that we're on. So I'd like to acknowledge and pay my respects to the Kaurna people, the traditional custodial owners of the ancestral lands that we're on today. I acknowledge their deep feelings of attachment and relationship to country, and respect and value their past, present and ongoing connection to the land and their cultural beliefs. And I'd like to pay special respect to any Aboriginal or Torres Strait Islander people who are here with us today. So firstly, it's my very great pleasure to introduce our keynote speaker to you today. Dr. James Muecke, AM, is here to speak with us today. So James, I'm sure, is known to all of you. He's an ophthalmologist, an eye surgeon and Australian of the Year 2020. He's going to be speaking to us today about giving us his keynote entitled Blinded, which is the story of Neil Hansen, a man who woke one morning blind in both eyes due to diabetes. So James is a fabulous, interesting and engaging speaker. He's a very powerful policy advocate, and I know you'll enjoy hearing from James. So please join me in welcoming James.
Thank you, Caroline. Possible to turn down the lights a little?
Yep.
Oh, great. Beautiful. We can... No, just the... You can leave the back on, actually. Perfect. Fine. Thank you very much, Caroline, and lovely to be here this morning at your symposium, and thank you so much for inviting me to come and speak. So as Caroline said, I'm an eye surgeon, and I've been an eye surgeon now, amazingly, for about 32 years. And for 32 years, I've been dealing with the consequences that diabetes inflicts on the eyes. In fact, every year, I'm seeing more and more patients who are losing vision, even going blind due to their diabetes, but in particular type 2 diabetes, which makes up, as we know, about 90% of cases and is a largely avoidable man-made dietary disease. Now, can you even begin to imagine waking up one morning completely blind? It's impossible to comprehend, isn't it? But one of my patients has had that experience. His name is Neil Hansen. An everyday Aussie bloke with a wife and 4 kids. He constructs light machinery for a living, and he also has type 2 diabetes. And a few years ago, at the age of 50, diabetes changed Neil's world forever. Unfortunately, he neglected his health, and then he neglected his diabetes, and he paid the price. He went to bed one evening with normal sight and woke up the next morning blind in both eyes. One of my colleagues worked really hard to try and retrieve his sight, but unfortunately it was too late. Neil was to spend the rest of his life in darkness. This is how Neil sees the world these days.
Basically, I think I would describe it as seeing everything as emotion, not as an actual vision. The images, unfortunately, aren't clear. The images are basically what you see of a day through your eyes is what you see of a night through your eyes. So there's no clarity. I see black figures as people or animals or trees, just black onto a greyish background.
So Neil lost his driving licence, he lost his independence, and he lost his ability to teach the javelin, which was his hobby. In fact, it was a passion that gave him a lot of joy. But the thing that upsets Neil more than anything is that he can no longer see the beautiful smiles on the faces of his wife and his grandkids. This is a picture of Neil's wife and 2 of his grandkids. This is how he should see them. But this is the reality. Neil has been irreversibly blinded by his type 2 diabetes. And Neil's not alone. He's just one of over 100,000 Aussies with sight-threatening eye disease due to their diabetes. So how does diabetes threaten the sight? Well, it damages the blood vessels throughout the body, including the retina, which is the light-sensitive layer of tissue that lines the inside of the backs of our eyes. So this is a picture of the macula, the central vision area of the retina in a patient with type 2 diabetes. And this is that same eye a short time later. So diabetes can cause bleeding inside the eyes that can take away the eyesight in an instant and sometimes permanently. But the important point here is that nearly all of the loss of vision and blindness due to diabetes, something like 98%, is preventable or treatable. And yet, to avoid the blinding consequences of this disease, patients with diabetes need to have their eyes checked on a regular basis. In Australia, of the 1.7 million with diabetes, well over half are not having their regular, all-important, sight-saving eye checks. And that's why it's now become the leading cause of blindness amongst working-age adults in this country. It's also the fastest-growing cause of vision loss in Aboriginal people. So for me, as an eye specialist, to see people go needlessly blind due to their diabetes, it makes me upset. But the thing that makes me really angry is this disease should not be happening at all. So type 2 diabetes was rare in the 60s. These days, we're seeing about 250 new cases being diagnosed in this country every single day. That amounts to over 100,000 new cases being diagnosed in Australia every single year. So this morning, I'm going to talk to you about type 2 diabetes, how it's arisen, why it's a growing epidemic, and we're also going to look at some strategies to curb this rising tide that's a serious threat to our health system, indeed, to our society. So my introduction, I mentioned that it's a largely avoidable dietary disease. What did I mean by that? Well, three main components: sugar, refined carbohydrates, and the seed oils. So let's look at these each in turn. So firstly, sugar. When we talk about sugar, we often think of table sugar, what we stir in our tea and coffee. But it's important to remember there's another very abundant form of sugar, the refined carbohydrates. So products such as white flour, white potato, white rice, and the foods made from these. These are all virtually pure starch. And starch is simply a long chain of glucose which is broken down into single glucose molecules when it reaches the gut. In fact, it's a process that begins as soon as these products reach our mouth. And so when you're consuming refined carbohydrates, you're pretty much consuming pure sugar. And it's really important to remember that sugar and refined carbohydrates are nutrient poor and non-essential. There's not a single biochemical process in our bodies that demands that we ingest them. For me, this was second-year biochemistry, the Krebs cycle, which some of you will recognise. We can actually obtain all the energy we need from the protein and healthy fats in our diet. And yet, our Australian Guide to Healthy Eating, which is based on our Australian dietary guidelines, is packed with products made from refined carbohydrates and also products that are relatively high in sugar. So how can this document truly be considered a guide to healthy eating? So let's go back to table sugar. So sucrose is made up of equal parts glucose and fructose. And the body handles these two substances in completely different ways. So let's look at them each in turn. So firstly, glucose. When glucose is absorbed into the bloodstream from the gut, it triggers the release of the hormone insulin from the pancreas. And the insulin helps move the glucose into every cell of our body where it's either stored or used as an energy source. So when I talk about glucose metabolism, I like to use the analogy of a subway train in Tokyo, where the train carriage is the cell, the passengers are the glucose molecules, and the conductor is the insulin. With prolonged and excessive intake of sugar, the cell starts to fill up with glucose. The insulin level rises to help try and push more glucose into the cells, but it reaches a stage where we can't push any more glucose into our cells. We are now resistant to the effect of insulin. We are what's known as insulin resistant. And there's an overflow of glucose back into the bloodstream, and this is taken up by the liver and converted to glycogen where it's stored. But the glycogen stores are limited, and so the liver starts turning the glucose into fat, which is exported away from the liver to healthy fat cells throughout the body. It's actually a type of protective mechanism. But when the production of fat by the liver outstrips its ability to be exported away, the liver then starts to take on that fat, and we develop what's called a fatty liver. Now, we all know what a healthy liver looks like, right? It's a deep red colour. Well, this is a picture of a fatty liver, and you can see it's yellow because it's absolutely suffused with fat. Now, a great example of a fatty liver comes from the French culinary delicacy, foie gras, which actually means fat liver, and is created by force-feeding geese refined carbohydrates in the form of high-starch cornmeal. So a fatty liver can develop in these unsuspecting creatures in 10 to 14 days. In humans with excessive fructose intake, a fatty liver can develop within a couple of months. So let's look at fructose. It's at 50% of table sugar, which gives sugar its sweet flavour. It's not recognised as a food by the body. It doesn't trigger the release of insulin. It actually suppresses our appetite control system. And when it's absorbed into the bloodstream, nearly all of it is metabolised by the liver, and about a third is converted immediately to fat. So it's actually much more toxic than glucose in giving rise to a fatty liver. So the third main component I mentioned were the seed oils, what we euphemistically call vegetable oils. So products such as canola, safflower, sunflower oil, vegetable oil. These are rich in inflammogenic omega-6 fatty acids and have been independently linked to insulin resistance, a fatty liver, and a whole range of chronic diseases, including type 2 diabetes. And so these three components are sugar, the refined carbs, and the seed oils are the major components of ultra-processed foods, what I prefer to call ultra-processed food-like substances. Dangerous substances that once again have been linked to a whole range of chronic diseases, including type 2 diabetes. They're like a loaded gun that's pointed directly at our livers, causing metabolic dysfunction. So this is a picture of a normal healthy liver, a pathological specimen, and you can see the densely packed cells there. And this is a fatty liver. You can see it's distended, and the white spaces are cells which are full of fat. Now, it takes on average 13 years to develop type 2 diabetes after we become insulin resistant. In children, however, it can develop in as little as 2 years. Now, it's a complex metabolic process that also includes the development of a fatty pancreas. But ultimately what happens is that the liver becomes so full with fat, it then starts to export the fat away from the liver. It can't take any more on, and it exports it away as triglyceride. And it's the high triglyceride level in the blood, combined with a high insulin level, which combine to give rise to the fatty plaques, which block the blood vessels throughout the body. And this, in turn, gives rise to the many life-changing and life-threatening consequences of type 2 diabetes. So what are some of these consequences, these complications? It can affect both the small blood vessels and the large blood vessels. With the small blood vessels, we can see numbness, tingling, even pain in the extremities. Now, we've talked about loss of vision and blindness, and we've talked about bleeding inside the eye, but the most common cause of loss of vision in diabetes is what we call diabetic macular edema. So what happens is that the fine blood vessels around the macula can be damaged, and you get leakage of fluid into the tissues of the macula, and those white flecks are deposits of lipid within the tissue of the retina. You can see it's abutting the fovea and threatening the sight. And this is a cross-section. This is a diagram from a device called an OCT, optical coherence tomography. And this is a different patient, but the top two images are from the right eye. And on the top right-hand side, you can see a cross-section through the macula. That's the way it should look. But the left eye, the one below, you can see that little raised area at the fovea. This is fluid which is collecting in the tissues of the retina at the very centre, causing blurring and distortion of vision. So when we start to see this outcome in patients with diabetes, we need to treat. And the most common treatment these days involves an injection into the eye of what's called an anti-VEGF. It's an antibody that helps seal up those leaky blood vessels, allows the fluid to reabsorb, and hopefully the vision to improve or at least stabilise. Now, I've collected some data from Medicare recently, and you can see we started giving those injections back in 2016, and you can see the growth in the number of injections every year, which really mirrors the growth of type 2 diabetes in our society. But in 2019, over 93,000 injections were given, and I suspect now at the end of 2021, we're up over the 100,000 mark. So there's 100,000 injections which have been given for a disease which we should not be even seeing at all. Damage to the blood vessels in the brain can lead to dementia. So about 70% of patients with type 2 diabetes will ultimately develop dementia. So this is a disease that impacts not just on the individual, but also on the family. And having lost a father to dementia a few years ago, I realised how heavily this does impact on people that love the individual with conditions like type 2 diabetes. Damage to the blood vessels, the fine blood vessels of the kidney, can lead to kidney failure. And when the kidneys fail, the blood needs to be filtered by dialysis, up to 7 hours a day, 4 days a week. And I've calculated that in Australia, every year, 4.5 million hours are spent by patients with type 2 diabetes hooked up to a dialysis machine. So this is time lost to their family and friends, the things they love to do, and also to the workforce. So not a great way to spend one's life. Damage to the large blood vessels throughout the body can also have catastrophic consequences. So damage to the blood vessels supply the legs can lead to gangrene through what we call peripheral vascular disease. And of course, a foot like this needs to be removed. So in Australia, every year, over 4,000 amputations are performed for patients with type 2 diabetes in this country. That's over 10 every single day. And here's our friend, Neil Hansel, in his hospital bed in March last year after his left leg was amputated due to gangrene from his type 2 diabetes. In fact, this was his 9th amputation over a 14-month period. He's also had 2 heart attacks, as well as being blind in both eyes. So this is also a deadly disease. About 80% of patients with type 2 will ultimately succumb to a thromboembolic event, such as a stroke or a heart attack. Type 2 diabetes is said to be the 6th biggest killer in our society. But if you actually factor in its major role in those top 3 killers, so heart attack, dementia, stroke, then I suspect type 2 diabetes is the biggest killer that we have in our midst. And last year, the first year of the pandemic, we lost over 15 times more lives to type 2 diabetes than to COVID-19. So this is the silent pandemic that's been largely ignored by our government. And the other really important fact is that if you have a chronic disease such as type 2 diabetes, you're more than 12 times more likely to die of COVID-19. So the best weapon that we have to fight this virus is to improve our metabolic health. Now, type 2 is also an incredibly expensive disease. It's costing our health system about $20 billion every single year. But if you also factor in those other 3 diseases I mentioned, and also the major role that insulin resistance and type 2 diabetes plays in hypertension, and it's also its potential role in cancer, then I suspect that the cost to our health system is many-fold higher than this, perhaps even approaching $100 billion every year. So how did this all come about? Well, humans are hardwired to love and seek out sweet things. So it's an ancient survival mechanism that helped our early ancestors to survive extended periods of fast, which were common early humans. It also allowed them to avoid bitter and potentially toxic foods in their environment. Prior to the 1600s, sugar was an expensive commodity. It was the domain of healers and holy men, and an indulgence that could only be afforded by the wealthy and the powerful. Over the next 300 years, the rising availability and popularity of sugar due to the booming sugar trade led to diminishing costs, turning sugar from a luxury item to an everyday necessity. These days, sugar is cheap, and sugar is absolutely everywhere in our lives, isn't it? But things took a turn for the worse in 1980 when the Dietary Guidelines for Americans was released. It was noted in the decades after World War II that there was a rise in heart attacks. And this was thought to be due to a fatty diet causing fatty blockage of the coronary arteries. So on no strong scientific evidence. In fact, on flawed and corrupted scientific evidence, the recommendation was to reduce the fats in our diet. And when you strip fat out of your diet or out of foods, you strip out its flavour and you strip out its ability to make you feel full or satiated. So something had to replace that, and that were carbs. So this low-fat, high-carb dietary recommendation exists to this day across the globe and in our own Australian dietary guidelines, which actually have a more extreme low-fat, high-carb recommendation. So what's been the result of this experiment? Rather than see a downturn in heart attacks have soared, along with it type 2 diabetes. In fact, there's been more than a 4-fold increase in type 2 diabetes across the globe since 1980. And this has been more profound in some communities and countries. So in China, for example, there's been more than a 10-fold increase in type 2 diabetes. And this is somewhat paradoxical because the Chinese diet is high in refined carbohydrates in the form of white rice. But as well as consuming a much more highly refined type of rice, we've seen an increase in sugar consumption across Asia, amounting to about 5% every year. And type 2 diabetes is also devastating Aboriginal people. We've seen more than an 80-fold increase in type 2 diabetes in the last 40 years. And I have no doubt that the modern diet, sugary drinks, ultra-processed foods, is driving this absolute travesty. And if we look at the Australian Guide for Healthy Eating for ATSI people, you'll notice there, once again, it's full of products made from refined carbohydrates and also a number of recognisable ultra-processed food-like substances. So this is a diet that's far removed from their traditional way of eating, a diet that's highly unlikely to make them healthy and strong. And type 2 diabetes is impacting on people in lower socioeconomic areas in particular. South Australia, sadly, leads the country for type 2 diabetes. But let's have a look at this map of Sydney. You can see the red area, Greater Western Sydney, has the highest prevalence of type 2 diabetes. In fact, 50% of the adults over the age of 24 in Greater Western Sydney have pre-diabetes or type 2 diabetes. So for the first time in our history, we are overfed but undernourished. And something that's concerning me very much is the fact that we're now seeing type 2 diabetes in our children. This was a disease when I was in medical school that was called maturity onset diabetes. We're now seeing type 2 diabetes in children as young as 3. And another concerning statistic, I don't know if you saw this just a month or two ago, Northern Australia leads the world for type 2 diabetes in our children. So this is an absolute disgrace. And there's a concerning upward trend. So the majority of children will have obesity by the age of 35 if we don't take action now. In particular, if we don't take action to reduce our consumption of ultra-processed foods, which make up 62% of the British diet, over 50% of the American diet, and I suspect we're quite close to that amount here in Australia. So we need to reduce our consumption of these ultra-processed substances, and in particular, we need to reduce our sugar intake. But there are a number of factors which make this a really difficult thing to achieve. And I've come up with a concept that I've called the 5 A's of sugar toxicity. So addiction, alleviation, accessibility, addition, and advertising. So let's Just go through those each in turn. So firstly, addiction. So sugar is highly addictive. It's been shown to be as addictive as nicotine. Its consumption activates the reward centre in our brains, leading to the release of the neurotransmitter dopamine. It's what makes us feel good. It's what makes us want to do it again. And it's ultimately what gives us those cravings. And like drugs, the more we ingest, the more we need to give us that feel-good hit. So it becomes a vicious cycle that's really hard to break. Second A is alleviation. We often use sugar to alleviate stress or to make us feel better when we're down. When we're stressed, the body is flooded with the stress hormone cortisol. So the brain needs to balance this up by releasing feel-good chemicals such as dopamine. And so as we've seen, sugar does a really good job of that. The third A is accessibility. As I mentioned, our world is absolutely flooded with sugar. You can't walk into most service stations without being confronted by a wall of confectionery. You can't check out from most supermarkets and stores, even post offices and chemists these days, without being seduced by half-price chocolates and soft drinks. And this is 2 vending machines in the study area of this building. I took it last year and it was absolutely packed with sugary products. So our major bastions of health in this city are not even setting a good example. So the fourth A is addition. An astronomical amount of sugar is added to our food and drinks, something in the order of 75%. And this is particularly problematic in remote communities, in particular Aboriginal communities, where sugary drinks and ultra-processed foods are in abundance and relatively cheap, and fresh and healthy food, often scarce, relatively expensive, and sometimes even out of date. And I don't know about you, but I can barely read those nutritional labels on the packets of food, let alone understand them, and they certainly don't tell us the amount of added sugar contained within. So we have a health star rating system. It's a system which is flawed. It's flawed because only about 30% of manufacturers use it. But it's also flawed because a number of unhealthy products, relatively unhealthy products, get a healthy 5-star rating. So this is a device that's been created by industry for the food industry, not with our health in mind. And there are over 260 different names for sugar, and this is 56 of the common ones which are used on the packets of ultra-processed foods, only serving to confuse the consumer even more. So finally, advertising. Our world is flooded, as I said, with TV commercials and ads for sugary products, sometimes in the most insidious of ways. And this has quite literally been going on for decades. Now, who's heard the phrase, breakfast is the most important meal of the day? Raise your hands. Breakfast is the most important meal of the day. Virtually everyone in the room has heard that. And guess who popularised that? John Harvey Kellogg, to market his newly invented breakfast cereal in 1906. I reckon it must be the most enduring marketing campaign ever. And yet, to this day, there's not a shred of evidence to back up his claims. In fact, most of us will do better without having cereal for brekkie. So we're going to need to address these 5 A's of sugar toxicity. And we need resilience, right? When I talk about resilience, I like to use the analogy of Mr. Spock from Star Trek. He's a very cool-headed and resilient character, isn't he? And I know what he'd do. He'd look to the smoking epidemic to see what's causing its decline. So back when Spock first graced our screens, smoking was socially acceptable. In fact, in the years after World War II, something like 80% of men smoked cigarettes. Have a look at this ad from the 50s and look at the caption on the packet of those candy cigarettes, just like Dad. So the realisation of the health dangers of smoking in the 60s, the banning of advertising for cigarettes, the taxing of tobacco products, and the rollout of hard-hitting and graphic awareness strategies such as these that we all know very well, have all made smoking socially unacceptable. And as a result, smoking and smoking-related diseases and deaths are on the decline in most countries. Not so sugar consumption, type 2 diabetes, and its complications, which are on the rise. So we need more than resilience. We need action. So I'm calling on my favourite action figure, Arnie. And I know what he'd do. So he'd look at these three overarching strategies of awareness, accountability and assistance. So let's, again, look at these each in turn. So firstly, awareness. Awareness that our poor diet is responsible for more disease and death than smoking, alcohol and inactivity combined. Our diet, as I mentioned, which is high in ultra-processed substances. So it's not just obesity and type 2 diabetes. Tooth decay. 40% of our 10 to 12-year-olds have decay in their adult teeth. And this is the leading cause for days lost to school and for surgical admission for kids. Once again, an absolute tragedy which has been largely ignored. And this awareness, this vital education, needs to begin in the earliest years, preschool. Actually, even earlier, during pregnancy. Seeing a rise in gestational diabetes across this country. So glucose crosses the fetal blood barrier and insulin does not. So we're actually priming our children for a range of behavioural and chronic diseases before they're even born. We also need awareness of the toxic impact of sugar and those 5 A's of sugar toxicity. I'm a medical doctor and I wasn't even aware of the addictive nature of sugar until a couple of years ago. I suspect that the whole world is addicted to sugar. I certainly was, and probably still am. This is my weakness, ice cream. And there's rarely been a day that I haven't had a bowl of ice cream after dinner. But early last year, I received a bit of a shock. I had a scan of my abdomen, and lo and behold, I had a fatty liver. In fact, that's an ultrasound of my fatty liver, fortunately mild. But you can see me, I'm tall and thin, right? I'm what they call toffee. Thin on the outside, fat on the inside. And this is a really important point. There are now more thin, metabolically unhealthy people than there are overweight or obese, metabolically unhealthy people. So although obesity is the biggest risk factor for type 2 diabetes, there's more to this than just obesity. It's not even the number of calories we're consuming, it's actually the type of calories, and particularly the fructose and the seed oils. What we should all be aspiring to are hotties, healthy on the outside, thin on the inside. So second A, alleviation. Rather than reaching for a block of chocolate when you're feeling down, there are healthier alternatives. Get out into nature, go for a walk, a cycle, a run, somewhere beautiful. Listen to your favourite musical playlist. Reach out to someone who's having a tough time, do a good deed. These have all been shown to be as effective as sugar in balancing that cortisol reaction that's flooding our bodies during anxious times. And there's also good news here. Type 2 diabetes is largely preventable. But it has to start with an overhaul of our dietary guidelines, our national dietary guidelines, which are outdated, they've been biased by the food industry, and they're flawed. They're flawed because they continue to encourage the consumption of seed oils, which I've said have been linked to chronic diseases, and they continue to discourage the eating of natural saturated fats found in foods such as these. Natural saturated fats that have never been linked to cardiovascular disease. Now, there are now over 20 systematic reviews backing this claim up, and this is one that was released in the middle of last year by the American College of Cardiology. And there are 4 Cochrane reviews, the highest level of evidence exonerating natural saturated fats and foods such as these. This is absolutely critical information that we all need to know. So we also need to be aware that type 2 diabetes is potentially reversible. There are now 3 clinically proven methods for putting type 2 diabetes into remission. And here they are. Bariatric surgery, very low-calorie diets, and low-carbohydrate diets. So let's look at those each in turn. So firstly, bariatric surgery. So bariatric surgery is a range of major abdominal operations which are risky, which are expensive, on a healthy organ, on a normal organ, for what is a dietary disease. So surely, first line should be a dietary approach to a dietary disease. And there are, fortunately, very low-calorie diets and low-carbohydrate diets. So very low-calorie diets rely on ultra-processed foods. They're an 800-calorie-a-day diet, which is essentially a hunger diet. They're nutritionally deficient, they're not sustainable, and they rely on a lifetime dependency on your willpower. So I'm not a big fan. I am a fan, however, of low-carbohydrate diets. So there are now over 100 controlled clinical trials to show that a low-carb, healthy fat diet can both prevent and reverse type 2 diabetes. And here's just one of them, which shows that over half of the subjects with type 2 were still in remission 2 years in on a low-carb diet. And I'm now having this experience with my own patients. I'm not sure if any of you saw the Sunday Mail article a few weeks back. I actually have over 100 patients with sight-threatening diabetic retinal disease. So that doesn't include all of the patients who I'm screening for diabetic retinopathy and the patients who have what we call background or mild diabetic retinopathy, which is not vision-threatening. I have over 100 who I'm actively treating at this stage. And I asked every single one of them, are you aware that your diabetes could be put into remission? Only 2 out of that 100 were even aware. So this is a message that's not even getting out to our general practitioner community. So I wrote to the GPs and I said, could we please explore the opportunity to put our patients' type 2 diabetes into remission? And I'm now seeing the results. And this is just 2 of my patients who have had staggering results. I actually had one patient that was able to reverse her type 2 diabetes in 2 weeks. And the lady on the left there, she had type 2 diabetes for 15 years and she is now in remission. Off her insulin, off her medications, dropped a bunch of weight. She's never felt better, seeing better now. It's one of the most satisfying experiences I've had in my clinical career. And it's an experience that I want all of my colleagues to have as well. And the great news is that Diabetes Australia now has a position statement for remission. It's still a rather pessimistic document, but it's one step further. On their type 2 diabetes webpage earlier this year, the very first sentence was, type 2 diabetes is a progressive disease. And I was on the National Diabetes Strategy refresh last year. And as a result of my advocacy, we now have remission in this document for the very first time, giving hope, not just to GPs, but to the 1.7 million people with type 2 diabetes across this country. And did any of you see the Michael Mosley documentary on SBS? So it's a 3-part documentary series. It was, I think it was in October, November. But it's also available now on SBS On Demand. And I was lucky enough to be involved in that documentary series, certainly one of the highlights of my year last year. And we need to be awareness. Patients who have type 2 diabetes need awareness of the complications of their disease. Here's Neil Hansel trying out his new prosthetic leg. When he first developed type 2 diabetes, he had no idea of what lay at wait for him. And 3 years ago, in late 2018, Neil helped me create a TV commercial. And here it is.
I should have kept my medication up and I should have followed the plans that were given to me by my doctors. I woke up one morning completely blind. Thought I was dreaming, went back to sleep for an hour, woke up and I was still completely blocked off. My wife's face when we went to bed. That was the last clear image I had.
Pretty heart-wrenching, isn't it? Very powerful 30 seconds. So that TV commercial played for about 6 weeks in late 2018 on Channel 7. But it played as a community service announcement, so probably only seen at 2 o'clock in the morning if you were watching TV. But such ads need to be seen during prime time, across all the channels, and for an extended period. So the second overarching A is accountability. So accountability of businesses and industry, and ultimately of our government to do the right thing by the people of Australia. And accountability when it comes to the toxic impact of sugar. So particularly the addictive power of sugar and ultra-processed foods. So we need accountability of businesses who are preying on our addictions, who know the withdrawal symptoms of sugar detox. Businesses and their industry allies who are preying on our addictions, preying on the vulnerable, and preying on our children and on their parents. And accountability of our government who allows this predatory marketing to continue in our diabolical food environment. And we also need to see accountability of parents and grandparents. Sugar is the only addictive substance that we give to our babies. And we need accountability when it comes to accessibility, as well as the vending machines I found here. These were 2 vending machines in the foyer of the Women's and Children's Hospital last year. Once again, absolutely packed to the brim with sugary products. And we need accountability at schools, what's being sold in canteens and tuck shops by contractors, and what's being used as fundraisers in the classroom. And we need accountability when it comes to addition. We need a clear and transparent labelling system telling us exactly how much sugar and what type of sugar is contained within. And we need accountability when it comes to the Health Star rating system. You might recall that orange juice earlier this year was downgraded from 5 to 2 stars. So how could a glass of orange juice, which has almost as much sugar as a glass of cola, possibly receive the healthiest 5-star rating? And is this the future for those soft drinks, energy drinks, flavoured milks in our fridge? And this is where the rather contentious issue of a levy or a tax on sugary products comes in. But there is some solid evidence and good reasoning behind it. In the 10 years leading to 2017, we saw a 30% increase in sugary drinks consumption in this country. Sugary drinks consumption has been connected to type 2 diabetes in many, many studies now, and in many studies in many countries, a tax or a levy on sugary drinks is shown to reduce purchase and consumption. So it certainly makes sense to me. But as you can see, it's just one of many strategies. Just by itself, it's not going to work. And it's been modelled that just a 20% tax on sugary drinks would raise over $600 million every single year. And that money could be put into awareness strategies, for example. So finally, we need accountability when it comes to advertising. So our kids are exposed to 3 commercials for unhealthy products in every hour on free-to-air TV. Our teens are exposed to 100 promotions for unhealthy products every week on social media. There absolutely is no escape. And once you see it, it's very hard to unsee it. And finally, we need assistance. And we need assistance at multiple different layers. Parents need assistance to what to pack in their children's lunchboxes. Teachers need assistance to guide their students to a healthier future. Medical students need assistance. My son was in medical school here, second year last year. He had the opportunity to do nutrition as an elective. So nutrition science isn't even compulsory in many of the major medical schools across the country, and yet this is the biggest health crisis that we have. And doctors need assistance, particularly GPs, to have the education, the resources, the time, the financial incentives to have these critical discussions with their patients. And patients need assistance. Many who are physically dependent or addicted to sugar, we need self-help groups and helplines, as we've done for nicotine and alcohol addiction. And people in poorer areas need assistance so they can have access to subsidised healthy foods, real foods. And I do like this quote from Dr. Gary Fetke, who's an orthopaedic surgeon in Tasmania. Eat fresh, local, seasonal whole food based on your environment and cultural beliefs, avoiding added sugar and ultra-processed foods. If we all followed Gary's advice, we'd be in a lot healthier space. I come back to the really critical point of awareness. And here's another TV commercial that I created last year in conjunction with Neil Hansel, showing the impact of type 2 diabetes on the family.
To Papa, you are the best papa in the world, and have a happy Christmas. Love from Anya.
That TV commercial is actually playing nationally at the moment on Channel 7. Has anyone seen it? And once again, we do need to see these ads in mainstream TV across all channels and during prime time. So as an eye specialist, I never want to see another patient, another Aussie, another fellow human go needlessly blind due to their type 2 diabetes. As health professionals, as leaders in our community, I truly believe it's time to make Australia type 2 free. Thank you very much. Thank you. I'll just put one last slide up there. For people who are interested in following the work that we do with Sight for All, which is major focuses in Asia. That's an area which is home to half the world's blind adults and 2/3 of the world's blind children. That's why I actually received the award last year, and not because of my advocacy for type 2 diabetes, but I thought I'd use the platform to do just that. And so the hashtags down below are all about my journey as Australian of the Year and the work I'm doing around type 2 diabetes. So very happy for you to follow me. So I think may well be some question time.
Thank you. Fascinating presentation as always. So questions for James?
James, thanks for an amazing and interesting talk. I was wondering if diet drinks are related to diabetes type 2.
Yeah, so what we call, so the non-diet drinks are called sugar-sweetened beverages. I prefer to call them sugar-loaded beverages, but artificially sweetened beverages, ASBs, are sort of the euphemistic term. And so they rely on non-nutritive sweeteners, and something like 25% of the Australian population consume non-nutritive sweeteners. But they have been linked to a range of chronic diseases, once again including type 2 diabetes. But I think most importantly is that they actually maintain our addiction to sugar. So they still trigger the reward centre, and you still have that dependency on the sugary products. So, you know, perhaps it's a pathway from fully sugared drinks through to non-sugared drinks, but it's not something I would suggest anyone linger on for too long. And it's interesting, isn't it? Coca-Cola have now investing a lot of money in water, so they realise that the writing's on the wall.
Thanks very much for a great talk.
Thank you.
This is a public health audience where
Yes.
the more militant wing of the public health movement's happy to ban and regulate and do all those things. How do you walk the line when you do this talk to, say, a commercial audience, a food manufacturing audience?
It's a great question. I haven't actually been asked that question. So I've been kind of jumping up and down in this space for 2 years. That talk continues to evolve every time I give it. In fact, this morning I made some additions and amendments to it. So it's constantly evolving. But in the last 2 years, I've actually never given it to an audience, a food industry audience, and I have not had anyone sort of come out to attack me as a result of the presentation. No, not in a major way. I've certainly had some trolling on social media and so forth, and you realise that they've been planted there most likely by the food industry. But they really can't deny it. The problem is that the government's not holding them to account, as I mentioned before. They've just basically got free rein. And I suspect there is a huge amount of funding that comes into coffers, employment, and I suspect potentially even funding of electoral campaigns. So it's just not something we're seeing being addressed.
There has been a... Sorry.
In this COVID thing now, we're starting to see regulations and the backlash socially. It's a very difficult line to walk between the implications of some of the things you're saying, and I just wondered if you had any experience of navigating some of that difficult terrain.
Absolutely. So yeah, there are a number of experiences I had throughout the year, and one version of my talk I do go through a few of those things. So literally, I think the first week after I received the award and I gave my speech and talked about the impact of sugar, I got an invite to speak to the CEO of the Beverage Association of Australia. So I had a meeting with him. I met with all the major supermarket chains and stores during my year last year, and basically they defended what they were doing. There was no accountability. The one organisation that did act on my suggestion was Australia Post. They actually removed sugary products from checkouts at over 700 of their corporate stores. I wrote to the Broadcasting Commission suggesting they remove TV commercials. Again, no joy there. So it basically, I didn't have a lot of luck. And this is where I think the government ultimately is going to have to mandate some of these things. I mean, simply having sugary products at checkout counters, you can still go up the appropriate aisle and get what you want, but to have it rammed down your throat, particularly if you're trying to avoid those things. I know I mentioned my weakness was ice cream, and occasionally ice cream will find its way into our fridge, and it literally calls out to me. It's so powerful. So if you're trying to detox, if you're trying to be good, if you're sitting there, filling your car with petrol and there's 2-for-1 chocolates, once again, I've been guilty of buying those 2-for-1 chocolates and usually eat both of them before I even get home. So it's so the environment that we are surrounded by is so alluring, isn't it? And so it should not be seen as nannying to remove some of those, particularly the predatory tactics of the food industry.
I mean, one of the other things that I think is interesting, James, and where you've had some influence is around changing professional associations' positions, and you've talked about the Diabetes Association in your work, and then one of the other things that I know you've campaigned a lot for and I think is shifting a lot is the disclosure of interests. So I think in, probably in dietary guidelines and in nutrition science, there is a lot of funding, and if that funding's not disclosed, then we don't even begin to know. I think, where the funding comes from is complex in nutrition, and there has to be an alternative source. But if we're not even disclosing conflicts or disclosing sources of funding, then where are we in science? So I think that's a really important thing that you've been advocating for in science as well.
Yeah, thanks, Caroline. Yeah. Well, we know that if food industry funds a study, that's nearly 8 times more likely to show a result in favour of that industry. And there's a really fascinating one that where the study looked at sugary drinks, and 33 out of the 34 studies that were not funded by industry showed that there was a linkage between sugary drinks and obesity and type 2 diabetes. And none of the 26 which were funded by industry showed a link. So you can see how the food industry absolutely sways, and it's very insidious, and there's a number of reasons for that. But it's me. I'm a doctor. I come from a place of empathy with my patients, and I've suddenly found myself in a very hostile environment. It's actually been quite a stressful year, and definitely some aggressive bite back from people that don't want me to be talking about these messages. And the conflicts of interest, the vested interests, which in this space are primarily the corporate food industry and religious ideology out of the Seventh-day Adventist movement. They are quite insidious and everywhere, and it's amazing how powerful it is.
Thank you for a great speech. I'm interested in your thoughts around the current healthy guide to healthy eating, and the nutrition guidelines are currently under review.
Yes.
And whether or not you've had any thoughts on or are a part of that process. You speak about having some sort of resistance to some of your thoughts and suggestions, and I wondered if there's been resistance from in the nutrition world as well.
Yeah, so there's still 2 camps when it comes to saturated fats, particularly natural saturated fats, not talking about artificial saturated fats. There's still 2 camps. There's the high-fat camp and the low-fat camp, and this is something that once again, there is industry influence and religious ideology underlying much of that. But yes, so I met with Greg Hunt, and Greg Hunt said he was going to put me on the Dietary Guidelines Review Committee, and I applied to be on it earlier this year, and I wasn't accepted. But there was, in my application form, there was a box I had to tick. Have you actually been criticising the dietary guidelines on social media? And I suspect that was actually aimed perhaps at me. And as a result, I presume that that's why I wasn't actually included, under the guise that I don't actually have any formal training in nutrition science, which I don't. But I've really lived this for the last 2 years, and I'm pretty knowledgeable about it now. So I suspect that's what's driven it. And but I think it would have been a double-edged sword. I think perhaps being off the committee allows me to sit back and actually, and there's a number of us who are watching, the previous committee, the previous guidelines, absolutely infiltrated by the food industry. And we are currently looking at that now at the moment to see the conflicts of interest. The NHMRC, who actually oversaw the process and are overseeing the current process, I suspect were asleep at the wheel. The Dietitians Association of Australia, who are heavily funded by the processed food industry at the time, had the task to actually do all the literature search, and majority of the literature in that document been funded by the food industry, particularly the cereal and grains industry, who are a big funder of the Dietitians Association. So again, you know, and I don't know if any of you saw my National Press Club address on the 1st of December last year. It's you can actually see it now. I've re-recorded it because as a result of that address, Diabetes Australia made some changes, Dietitians Australia made some changes. I mentioned before that Diabetes Australia, as a result of my pushing them, have moved away from diabetes as type 2 as a progressive disease to now admitting that remission is possible. I'm now working on Dietitians Australia to actually release a position statement as well, and to start to embed remission and through the dietary approaches into their curriculum and for continued professional development for their members as well. So I'm continuing to work in this space, and hopefully, when the dietary guidelines are released, probably in 2024, we will see a move away from the demonisation of natural saturated fats, which has peppered dietary guidelines throughout the world, into a healthier space. But in the meantime, over 15,000 deaths every year, over 100,000 new diagnoses of type 2 every year. This is why we need an awareness campaign, and this is what I've been pushing the government to do, but still seems to be falling on deaf ears.
One last question here. Okay, thanks. Thinking of retinopathy, I suppose most of us never see an ophthalmologist and hope never to have to see an ophthalmologist, but a lot of us see optometrists quite regularly. I don't think any optometrist has ever had any word with me about diet. Do you think there's an opportunity there they could do more?
Absolutely, absolutely. So it's quite a big answer and lots of levels. So me as an ophthalmologist, as a medical doctor, until last year, I wasn't even aware that remission was possible. It's a progressive disease. I'm the guy at the end of the line treating the end-stage complications, thinking that any discussion about lifestyle is the realm of the dietitian, the GP, etc. So, and there's a number of reasons for that. Dietitians have been struck off by their overseeing body, Dietitians Australia, for giving low-carb advice to patients. Doctors, Gary Fettke, the guy that I mentioned that quote right at the end of my presentation, was actually struck off by our medical board. He was chopping the legs off his patients every week for type 2 diabetes, gangrene. He just started telling his patients, cut back on your sugar intake. He was reported by one of the dietitians at his hospital, struck off from our medical board, had a 2.5-year Star Chamber investigation, eventually was had a pardon. But so there's a fear element here amongst dietitians and doctors because of what's happened to our colleagues. And so now that we have remission in our national diabetes strategy, hopefully doctors will now feel comfortable having those conversations with their patients. So this, I think for me, this was the most powerful thing that I was able to achieve in my role. And hopefully many people are seeing this as a potential turning point in this avalanche of type 2 diabetes in our society. So exciting times, hopefully. We just need the various elements to get on board with it. I mean, if you realise that the dietary guidelines are so powerful, so they inform what's consumed in childcare all the way through to aged care, in prisons, in the Defence Force, in hospitals. They inform health educators, health practitioners, the food industry. They're very, very powerful. And so if we realise that these guidelines have made us sick, then there's huge potential for a civil lawsuit, I would have thought. because we're doing what we think is right. We're consuming the foods that we're told to consume. We've got to go high in carbs and low in fat. But it's actually been a disaster. So we get a reverse out of it, and perhaps they're just wanting to do it in a slow way. I don't know. But I think it's time for us to all say, sorry, we've got it wrong. Time to move on.
Well, I think we'd all agree that was a fascinating and thought-provoking and also very entertaining presentation. So thank you so much for talking us through all of that, and thank you for your advocacy as well for the health of Australians. So this is a small gift. I hope it's all right.
Thank you. That's lovely. Thank you. Actually, I saw. Thank you. Thanks, Caroline. Thank you so much, and thanks everyone for coming along today. I saw some of the slides of one of the upcoming speakers, and there looked to be some slides on alcohol.
Yes, they're next. Alcohol's next. We're not going to give them alcohol.
No. I'm glad you didn't give me chocolates.
Sugar. No, that's right.
Thank you very much.
All right, thank you so much. All right, so now we need to do Mike, although I'll need my mic. All right. Well, while we're swapping over mics, so our next two speakers are also very well known to everyone. So we have two speakers coming up next, Professor Jackie Bowden and Dr. Shona Crabb, and they're going to talk to us about the work that they've been doing recently around alcohol and drug policy. So, Professor Jackie Bowden is the newly appointed Director of the National Centre for Education and Training on Addiction at Flinders University, so NCETA at Flinders. So she's just left Adelaide Uni and Samri to move to Flinders, so we miss her already. So prior to leaving, Jackie was Deputy Director at the Health Policy Centre at Samri with me. She was also an externally funded research fellow here in the school. She has over 20 years' experience in public health, particularly tobacco and alcohol control, and her PhD focused on alcohol consumption messaging to reduce population consumption, which led to her receiving an NHMRC ECF focused on ways to reduce parental supply of alcohol to teenagers. Jackie's been a key advisor to the South Australian Government for 13 years. Now, shall I also introduce Shona? Yep. Yes. So Dr. Shona Crabb is a senior lecturer here in the School of Public Health with a background in health and social psychology. Her research focuses on community perspectives on health risks and health promotion messages, especially around cancer risk and alcohol consumption. And on understanding the social context of health behaviours in order to inform public health policy and practice. So Shona is the Director for Gender Equity, Diversity and Inclusion in the Faculty of Health and Medical Sciences. Excuse me. And she's an award-winning teacher of public health courses in the Bachelor of Health and Medical Sciences. So please join me in welcoming Shona and Jackie.
Thank you very much. And what a hard act to follow from James. Goodness me, no pressure. Thanks, Caroline. And I do miss you all already, and it's lovely to be back. So, on to our presentation, and I will hand directly over to Shona and we'll ask questions at the end. We'll get you to ask your questions at the end. Just a quick acknowledgement of country. We'd like to acknowledge and pay our respects to the traditional owners of the land upon which we meet today, the Kaurna people, and also pay our respects to the cultural authority of Aboriginal people visiting and attending from other areas of South Australia and Australia online. So today I'm going to talk you through the study background, the main themes and policy recommendations to reduce the harms from alcohol. I'll talk you through the broader study that Shona and I did, and we had a range of researchers on board with this project. So a huge thank you to our funder, the Ian Wilson Liberal Foundation, to our research team, Nathan Harrison, Dr. Ashley Bartram, Shannon Vanderkrook, and Dr. Scott Hansen-Easy. We had an expert advisory group that consisted of Professor Robin Room, Associate Professor Scott Wilson, Associate Professor Caitlin Hughes, Professor Caroline Miller, and Professor Ian Olver. We would also like to thank the 24 experts that we interviewed through this project. We had experts in policy, alcohol policy, other drug policy, research, treatment, and we had people working in Aboriginal and Torres Strait Islander settings as well. That's not all the names. Some of the people that we interviewed weren't able to be named because of their positions. But today I'll give you a bit of an overview. So the use of alcohol and other drugs places a significant burden on the health of South Australians, their families, the community and the health system. So our research was designed to answer the following questions. What are the current AOD, so I'll talk about AOD, so alcohol and other drug trends in South Australia, and how do these compare to national trends, and how has this changed over time, and what are the harms of AOD use, and potential policies that could be introduced to reduce the harms in South Australia. And then Shona's going to talk you through what we've done as a result of this research and where we hope it will land as well, and some of the findings. So we did a literature review to start off with. Scott Hansenese was involved in that process, and a synthesis of key data on use and impacts of alcohol and drugs in Australia and South Australia. Then we did interviews with 24 key experts, or what we'll call informants, working in South Australia in the national AOD sector. So we had 18 from the non-Indigenous population and 6 representing Aboriginal and Torres Strait Islander populations. I must admit, this is one of the most fascinating research projects I've ever been involved in. It was just fantastic to be able to, Shona and I did all of the interviews, and it was just incredible to the wealth of expertise we have across the country in this space, and to be able to pull it all together into this report was just really wonderful. So to start off, AOD use and trends. Now I've got some notes here, because this one is a bit of a challenging one. So as you can see here from the orange and blue lines up the top, we've got a downward trend, but alcohol is the most widely used drug in Australia. We've got 24.8% consuming in excess of the previous guideline for increased short-term risk, so that's increased risk of injury predominantly, and 16.8% exceeding the guidelines for long-term risk, so chronic disease and cancers. We have new guidelines now, but they weren't available for this report. The most prevalent drug behind alcohol was cannabis. And the line in the grey shows a slight increasing trend in cannabis use to 11.6% in 2019. Then we have approximately 4% using pharmaceuticals for non-medical purposes and cocaine. You can see a slight increase in cocaine use, so that's the green line. That's happening predominantly in the eastern states, but there is some concern that South Australia might start to follow suit. South Australia tends to follow kind of down the track. Ecstasy use is relatively stable at around 3%, and methamphetamine, despite hearing about it a lot in the media, prevalence of use is actually quite low at around 1.3%, but it's because of the harms to the individual and those around the individual that we're really concerned about methamphetamine. In terms of trends for South Australia, we tend to follow mainly the national average. The blue line shows what looks like a slight increase in drinking in excess of the guideline for long-term harms, but that actually wasn't significant. Ecstasy and cocaine use were lower than the national average, and most of the consumption of those two drugs happens over the weekends. But we are known for our methamphetamine consumption in South Australia, predominantly because of the wastewater results. Shona and I won't focus on this topic too much today because it's probably more appropriate for our collaborator, an Aboriginal man, Associate Professor Scott Wilson, to go into this in detail. But the data does tell us that for Aboriginal and Torres Strait Islander people, they're more likely to abstain from alcohol, which is very good news, but the percentage of risky drinkers is actually higher, and the harms associated with risky drinking are higher in Aboriginal and Torres Strait Islander people. We've got higher use for methamphetamine and pharmaceuticals, cannabis and heroin. Cannabis in particular is seen as a drug that's quite benign if you, in the community compared to, say, methamphetamine, which is seen as obviously a very a terrible drug to be using. And so cannabis is seen as quite this benign substance, but there is a lot of concern that Aboriginal communities, use is actually quite high and something that needs to be thought about a lot more, and we need some systems in place for that. And we also have comparable ecstasy and cocaine, we don't have enough data for fantasy and GHB. Okay, we asked experts to tell us which drugs cause the most harms, and alcohol came out strongly on top because of the harms to the self and others. So certainly without doubt, one of the quotes, alcohol remains the most commonly misused drug in the community and creates the most significant harm. Obviously with the exception of tobacco in regards to mortality, and after James's presentation, sugar probably fits in there as well. Methamphetamine came out a very strong second. While prevalence is low, there are absolutely significant harms to the self and to those around them. So to the self, violence, mental health. Now there's some emerging evidence around Parkinson's disease and the link between meth use and Parkinson's disease. We've actually got someone in the community here in South Australia, an expert working on a Parkinson's disease community campaign as well to highlight those risks. Pharmaceuticals in terms of harms tends to incur unintentional deaths, addiction and mental health issues. Cannabis tends to result in motivation issues, which can then result in poor schooling, especially if kids are smoking it during school. And we were told that a lot of Aboriginal communities, they're seeing this happen a lot. Psychosis as well, as I mentioned, is another issue. Fantasy and GHB, we didn't even have this on our list, but we were told very clearly early on, particularly those from SAPOL, that we are seeing more deaths due to overdose from fantasy. It's easy to access and it's very easy to overdose. Heroin, we're actually in a fortunate position. We don't have as much heroin use in South Australia as other states, but it causes a range of social and health harms. Ecstasy, mainly deaths due to toxicity of the actual drug itself. And cocaine tends to be more of a weekend drug, but it is resulting in cardiovascular issues if used regularly, particularly. So some general themes that came out of our interviews. Very strongly, AOD use needs to be framed as a health issue rather than stigmatised. So what we're finding is this war on drugs rhetoric that's been used for many years is actually preventing people from entering into the treatment system. So that's a big issue, and it's preventing people getting the help that they need with some of these AOD use. Alcohol consumption is incredibly normalised in Australia. In most of our events, we still have alcohol. It's very much a part of our culture, and we really need to be stopping and thinking about the harms. Social determinants of health came out incredibly strongly in basically every interview we did as well. So if we were working further upstream, looking at education, employment, housing, all of these factors underpin AOD use, and strategies to address these will have positive flow-on effects. So all the experts told us that. We also have, over time, more complexity in the cases that people are seeing. So polydrug use is more common than single drug use, particularly combined with alcohol and some other drug. It was really clear more action is needed to prevent the harms of AOD use in South Australia and reduce the burden on the health system. We're just not doing enough to prevent it. We're working at the treatment end, but we've got far too many people entering treatment and often in not enough places as well. And a lot of these policy recommendations that I'll talk through extend beyond our current practice in South Australia, and it's recommended to underpin the next AOD strategy. And so this report's actually been used to underpin consultations through the next AOD strategy that's out for consultation now in South Australia. A main thing that came out in the Aboriginal and Torres Strait Islander communities was that there's that data quality around AOD is problematic in use. So National Drug Strategy Household Survey data just doesn't get enough people from communities in it, and then you've got small numbers, all sorts of issues there. We need to prioritise the voices of community leaders and community members, and every community is different. Crime-based policies have had significant implications on community. There is a lot of concern and people not coming forward for treatment, particularly in methamphetamine, because they're worried about their kids being taken away from them. So huge issues there. Drivers of AOD use very clearly come out: boredom, lack of opportunities, higher unemployment rates, a sense of not belonging, plus self-medication for physical and psychological trauma. So there are intergenerational reasons why we should be caring. Racism, discrimination and marginalisation is happening right now, and it's happened in the past. Some people within the Aboriginal community have really suffered. And also people resort to it because there's nothing else to do, and many times people have told us over the years that nothing else to do and we can't get a job, we can't get anything, we might as well just get high. So really concerning. So I'm going to talk about the key findings in relation to alcohol, and then Shona's going to talk through the other drugs. And there are many parallels, and actually many parallels with James's presentation as well. So there's been a gradual decline, which is really good news in South Australians that drink in excess of the guidelines. But we still have 1 in 5 that exceed the long-term risks of long-term harms, and 1/4 for short-term harms. Aboriginal people, as I said, more likely to abstain, but more harms from drinking at risky levels. So we've got around 5,750 deaths per year responsible for alcohol, and it's the leading cause of death and disability in those aged 15 to 24 globally. And hospital and emergency presentations are increasing, so it's definitely an issue. While we're seeing some slight declines at the population level, we're still seeing a lot of burden in the community. So what are the drivers? It's influenced by culture and context. It's part of community cohesion, especially in regional communities. People come together around a pub and tend to drink. There has been a shift in time over time from drinking primarily in licensed venues, so bars and pubs and clubs, to now drinking in the home, and that's been really exacerbated during COVID-19. Also, there's supplier drivers. So alcohol industry have a strong influence on policymakers, a huge influence, especially in South Australia. Australian Hotels Association are incredibly powerful. Availability is changing as well. So we've always been concerned about density of alcohol outlets. Now we can have online delivery, so it can be delivered to your home within half an hour. And that is just completely changing the game for alcohol control. You can imagine if you've got some concerns with drinking, you see an ad, you can get it delivered to your door quickly. It's weakening all of our systems that we've had in place to help people with their drinking. As well, concerns around kids getting access to it very easily as well. So all sorts of issues, so we're working with state government around that to make sure they've got some good controls in place. Also concern around the China market dropping out and what impact that might have. We don't really know yet, but there is concern that industry might start dropping their price of products, and we know there's a strong link between price and use. So that's something that needs to be watched. So we asked everyone, what are the key policy responses that could work in reducing harms from alcohol in South Australia? And very clearly everyone told us, including respondents talking about Aboriginal and Torres Strait Islander communities, that implementing a floor price for alcohol in South Australia was a really key thing that needs to happen. So what a floor price does is basically reduces the price of the really inexpensive products like cask wine. So at the moment, you can buy cask wine at around 33 cents a standard drink. It really should be more up to the $1.50 a standard drink. So it's incredibly cheap. And this is where our problem drinkers are able to access alcohol products very cheaply. And we've seen it in Northern Territory. It's had really impressive results. And other places like Scotland, Russia, Ukraine, Canada have brought it into effect. And also Ireland is due to come into effect as well. Obviously, you need a communication strategy, though, to get people on side with this. You know, when you hear the price of alcohol increasing, you don't get too much community support for that. So that's something that needs to happen as well. Restricting advertising and marketing, so some parallels with James. Restricting it in sport, including via sponsorship. So young men are the group at the highest risk from harms from alcohol, and they're the ones that sport advertising of alcohol appeals to. If you look at the WHO on data of burden disease, alcohol is the lead contributor to years lost from death and disability in people aged 15 to 49. And that's the group that we're advertising alcohol to when we advertise it in sport. Also, restricting advertising in public places is an important strategy. So one easy one that could be done quite quickly is South Australian government property. Avoiding politician promotion of alcohol products in the media. So photo opportunities with alcohol products in hands, you'll see it happening a lot in South Australia. Now that I've mentioned, you might see it a little bit more. It's something that happens all the time. Reducing availability of alcohol through regulating online and home delivery of alcohol products. As I said, we need to be checking ID at the point of delivery, limiting the time of delivery, responsible service of alcohol, checking that people aren't inebriated when they're getting delivered their alcohol, and perhaps doing some responsible service checks as well. Funding education campaigns to raise the link between alcohol and cancer. We know that most people aren't aware of that link, but when they are aware of that link, they are more likely to stop and think about their drinking. And it could be a very good population strategy to reduce people's consumption back below the guidelines. Also increasing awareness of the alcohol guidelines themselves. We've had some changes in the alcohol guidelines. Many people remember them back from 2 iterations ago now. So we need to do more to just at least let people know what the new guidelines are. We've also got an issue with parental supply, so in teenagers. So many teenagers, or most current drinkers, are actually getting alcohol from their parents. And it's not because parents are negligent, it's because they're doing it because they think that that's the right thing to do and it's the safer environment for them to be drinking in the home. But they're not thinking about the effects on the brain and the fact that, unfortunately, kids, that when they get it in the home, they're also getting it outside the home as well. So they're just increasing their overall consumption. Call for volumetric tax as well to be applied nationally. Some secondary prevention strategies, so improve availability of early and brief interventions, particularly in regional areas. A full review of licensed premises to increase compliance, and using our existing legislation around harassment as well that's already in place that's not really been implemented properly. Thinking about things like, after a certain time of night, say midnight, switching sales from full to mid-strength alcohol. We've got a lot of places that are not selling, selling alcohol responsibly. So, and some tests that have been done in other states have found that 86% of people who went in and were showing 3 or more signs of intoxication were still getting served alcohol. So we're not really even checking that in South Australia at the moment. Maintain and increase treatment services is another important one. Implement sobriety tags is something that could be used for offenders who have committed alcohol-driven crimes, and that has been really shown to reduce domestic violence. So sobriety tags actually check the amount of alcohol in sweat and can be used very effectively. And consider the use of managed alcohol programs. They're called wet shelters, and they're where people who have an alcohol issue can go and access alcohol. Alcohol is actually one of the most dangerous things to detox from. So these wet shelters can actually put people on the path to recovery over time. Reinstate access to wholesales data. Release annual survey results in unpaid media, and talk about the good news stories, the fact that young people are actually starting to decrease their consumption. Highlight that. That can increase social norms around the fact that people aren't drinking, or some people aren't choosing to drink like they used to. Around Aboriginal and Torres Strait Islander communities, address data quality. There are some options like the GROG app that Scott Wilson is looking at. And they could be an important way forward in getting proper, more reliable data to influence our interventions. So in concluding thoughts around the alcohol space, alcohol consumption is culturally normative in Australia. I think we'd all agree about that. It causes significant harms that are really underestimated. We've got many of the policy recommendations that I've listed here were actually seen as relevant to Aboriginal and Torres Strait Islander communities as well, and that we need to just do a lot more to prevent these harms as a priority rather than dealing at the treatment end of the spectrum. So now I'll hand over to Shona. We'll just do a quick mic swap, so welcome to stand up and have a bit of a stretch if you'd like while we just swap this over.
Hi everyone, nice to see you. Let's make sure I've got that in the right spot. Okay, excellent. And I've got my little thingy. All right, thanks Jackie, and yeah, nice to see everyone here. As Jackie mentioned, I'm going to talk to you a little bit about the drugs and what we found in our study about other drugs other than alcohol. So Jackie's already talked a little bit about some of the trends in use and some of the harms associated with those drugs, so I'm not going to go back through that, but I'm going to tell you about some of the themes that came out of the interviews around the key issues that the experts are seeing in their work and some of the policy recommendations that they're suggesting would be particularly relevant in South Australia, but potentially applicable elsewhere as well. So firstly, as Jackie mentioned with alcohol, we asked people about the drivers of use, why we're even seeing changes in trends, why people use illicit substances at all. And many of the experts told us that pleasure seeking and deliberate kind of or conscious risk taking is obviously a driver for many people, particularly when we look at things like the weekend drugs and the party drugs, if you like. But beyond that, one of the really dominant themes, and Jackie's already touched on this in the earlier part of the presentation, but was around the levels of psychological and physical harm and trauma that exist in the community and the extent to which people are there then self-medicating. So not seeking appropriate treatment for psychological trauma or physical pain and then self-medicating those things. And that came through very strongly. Connected to all of these things, and you can see that these drivers are all interwoven together, but the social determinants and the social context of people's use was a really dominant theme that came through the interviews. So, I mean, some of the examples are up there on the slide, and these are complex, but it was very clear that these social determinants are influencing use, and they're influencing the levels of psychological trauma and harm as well. So it's a kind of multi-leveled things. In some communities, there are very culturally entrenched or normalised practices around drug use, similar to some of the alcohol use as well. And that sometimes means that communities are not even aware of the levels of risk and harm that exist. It's just a normalised kind of practice that these substances would be taken on. So those drivers I've spoken about so far are all very much demand drivers of use. The final one really was a supply driver, which was about the availability of drugs. Obviously, as different drugs are more or less available, we see shifts in trends over time. And we've seen a little bit of that with COVID-19 and border closures, making some drugs more available or less available. Particularly, informants often highlighted the rise of the dark net as being a way that people can access drugs very easily. And this quote I thought was really striking, that you can get your meth faster than you can get your takeaway pizza. So, you know, kind of gives you a little bit of context about how easy it can be in terms of a supply driver. Some of the other issues or other themes that were dominantly coming through the interviews that were associated with illicit drug use are really around things that exacerbate the harms on the risks of drug use. Jackie's touched on some of these already too. So the idea that we often frame drug use not as a health issue but as a stigmatised or a criminal issue can have a range of implications. It has implications at a public policy level, and it has implications at an individual level for people's help-seeking behaviour. People can be concerned about seeking help because of the criminal consequences consequences, the social welfare consequences, as Jackie mentioned, things like fear about the removal of children from a family. Also, the financial implications, whether they're perceived or real. We heard stories of things like people who wouldn't call an ambulance in the instance of a drug overdose because they were concerned about the financial implication of calling an ambulance. So the level of barriers around the way that we stigmatise drug use is quite problematic, and we don't see it typically as a health issue still. Obviously, resourcing for treatment and rehabilitation can be an issue, and that was raised repeatedly. And related to that when people do seek help from a health professional, the health professionals are not always well trained to be able to identify issues or support people. There were, of course, also issues about there are new drugs emerging sometimes, new drugs of concern. Jackie mentioned we didn't have fantasy on our radar, but our informants mentioned that to us as an emerging drug of concern. And there are also potency and toxicity changes in the drugs that are available, which change the level of harms and risks that are there in the community. So that needs to be monitored. So building on all of those themes about drivers and issues in this space, we then talk to people about what appropriate policy responses would be. And as Jackie did, I've grouped these in terms of primary, secondary and tertiary kind of approaches to prevention. So in terms of primary prevention, people talked a lot about having community education campaigns that are evidence-based in order to let people know about what the harms and risks are, particularly in those communities that are at risk and where the use is normalised or entrenched and they may not be aware. So raising awareness of that. But also that community education campaigns can be an opportunity to challenge the stigma at a broader community level. So the way we talk about drug use in these kind of campaigns can shift the dialogue in the broader community and can raise awareness about help-seeking opportunities. Importantly, because of that link with social determinants, programs and policies that work upstream were one of the very dominant kind of approaches that was talked about, particularly for Aboriginal and Torres Strait Islander communities, but for the community in general. And you'll see, again, linked to some of the things we've already talked about, that kind of quote there about trauma, boredom, lack of opportunity. So people identified if we can do things at a policy level to try and shift that social determinants, the context in which people live, then we might be able to do something about the risks and harms and the trends in the drug use. Importantly for Aboriginal communities, the support that's provided, the culturally appropriate support through the Aboriginal community-controlled health organisations was very much held up as very important. In terms of secondary prevention strategies that are looking to address the risk factors for harms, as mentioned, people talked about the fact that people were self-medicating for pain and trauma. So being able to provide people with appropriate and affordable access to treatments for physical pain or psychological pain and trauma would be a way to kind of move them away from self-medicating, from illicit drugs. So it's really important that we look at those kinds of things. But when they do go and seek help, as I mentioned, it's important that health professionals and particularly GPs are trained and they have the education and training to deliver the screening and early interventions. So we saw, quotes like this where people said, well, GPs mostly would ask a question about tobacco consumption. Many will ask about alcohol consumption, but virtually none of them will ask about drug consumption. And the main reason is that they don't know how to deal with the answer if they ask the question. So, we need to be able to kind of have our GPs equipped to actually do something when people do reach out for help there. And to find alternative treatments for pain or comorbidities if that's part of that picture. Importantly though, particularly in community groups that are at risk of harms, they may not listen that much to broader health promotion messaging or even to go and see health professionals. So peer education and support campaigns in some groups were seen as very important. There we go. It was also very important for there to be support and resources for families of users who, particularly in the context of methamphetamine use, were often, they didn't know where to go and how to seek help. And actually, since we've done this research, the Alcohol and Drug Foundation has launched a program called Path to Help, which is seeking to do some of that work to provide an information portal. So it's really great that some of these things are being picked up right now. Nationally, Nationally, we have a program that's around real-time prescription monitoring. In South Australia, that's called Script Check SA, where doctors and pharmacies can check people's prescriptions. So we can look at when there's oversubscribing of prescription medication. So people typically talked about this as a really positive step that we need to support. In South Australia at the moment, we've been on a trial of this program and it's not yet mandatory. So we need to continue to evaluate these kind of programs and look at how we can use them moving forward. Similarly, we need to continue to evaluate the available prescription medications. Some of the experts told us there are medications that are available on prescription that can actually be likely to lead people into addiction, and that we maybe don't need them at the level that they can be accessed in the community. So continuing those steps, sorry. And many people talked about pill testing at music festivals and other events. Obviously, in the context of the last couple of years, there haven't been a lot of music festivals and other events, but it's still a discussion that's ongoing about how we might look at reducing harms or the risk of harms by having pill testing. And I believe in the ACT, they're actually looking at having a static pill testing site that will commence next year. So that's another thing. ACT's been kind of a bit ahead. So we could look at the possibility of putting this in place in South Australia. A dominant theme in terms of more broadly looking at supporting mechanisms around users was a discussion that came up around partial decriminalisation of drugs. South Australia was quite leading the way in that with our partial decriminalisation of cannabis in the 1980s, and all of our experts talked really about what that would mean if we looked at partial decriminalisation more broadly. Often they referred to a model in Portugal that works really well to divert people to health services rather than a criminal process. But importantly, people talked about reviewing the evidence really closely to look at the appropriate model. In some models of this in places like the US, you see concerns about having a market-driven approach where people can make profit from selling the drugs. So that's quite problematic. So people did highlight that there could be unintended consequences of having decriminalisation. So really the suggestion is that we continue to review the evidence and have discussions about that, but look at how that could move it into a health approach rather than a criminal approach to drugs. We of course need to maintain and increase treatment and rehabilitation services, particularly in regional areas where people have to travel a really long way to get help, and it can be really disruptive for their lives. And as the quote there suggests, we need Aboriginal specific programs within communities. We need to work with communities to have appropriate treatment and rehabilitation. We could look at things like reviewing and reducing those costs associated with ambulance call-outs, as I mentioned, to reduce a barrier, and look at whether or not safe injecting spaces would be appropriate in the South Australian context. There's good evidence from interstate, although we do have a lot, we have less injecting drug users in South Australia. A few other important priorities that were mentioned. Informants noted the need to have a more integrated approach. We tend to look at drug use in fairly siloed kind of parts of the sectors that intersect with drug use. So we need to do a bit more, it was suggested, to bring together different kind of stakeholders, including police, health departments, government ministers, community agencies and users themselves, community members themselves. So we need advocacy and leadership in that space. Ongoing resourcing is required to continue to monitor the patterns and the trends and new emerging issues. And we, of course, as Jackie's mentioned, need to look at data quality, particularly for Aboriginal and Torres Strait Islander communities. Importantly, in terms of the supply drivers, continuing to resource SA Police is really important. That's our main kind of way to look at disrupting the supply of the illicit drugs. Just a few concluding thoughts. As Jackie said, many of the harms that are caused by drug use are actually more to do with the framing of the drug use as a criminal issue, rather than the health, consequences. It's about the barriers that are there to people seeking help. So we still have these effects from the war on drugs rhetoric, if you like, in our community. So more needs to be done to change this stigma, as well as to shift the social determinants that drive use and prevent treatment. And particularly when we're working with Aboriginal and Torres Strait Islander people, it's really important to work with community to do that. So in terms of our report overall, Jackie showed you a picture of it there in terms of what we've done with the report from here. We're suggesting that these policy recommendations, and obviously they're fleshed out a bit more in the report and we work through them all, should be considered particularly by the state government as part of the approach to reduce harms from alcohol and other drug use in the community. We have provided our report to members of Parliament in South Australia and alcohol and drug agencies, including South Australian Police, and we've provided that electronically and met with some people as well, which is great. So there's been a bit of interest in that. And we are in part of the consultation around the South Australian alcohol and drug strategy, the next strategy, using the report to help inform some of that discussion. We've presented our findings at a symposium at this year's Australasian Professional Society on Alcohol and Other Drugs conference, and we're going to make the report publicly available so that anyone who wants to access it can, but we're hoping to publish a commentary piece about the process and about what we found in that. So we'd certainly welcome opportunities to talk with people more about it or to look at developing the research agenda to underpin, to gain the evidence needed to move some of these policy recommendations forward. So thank you very much.
All right, thanks very much. Questions for Jackie? I know.
That's good. We can share.
Yeah, won't spit on it or anything. Questions for Jackie or Shona? Jackie and Shona? Yep.
Caroline. Jackie. Thank you both. It was a great presentation, very interesting and a bit concerning. We've had a pretty depressing morning, actually, with the presentation so far. Yeah. You mentioned about an early and brief interventions as one of the ways of dealing with it, and you said something about Medicare numbers. I just wondered if you could flesh that out a little bit.
Yeah, so at the moment there is a Medicare number, as I understand, but I think a lot of GPs aren't using it and they're not really knowing how to best make use of it. So I know the PHN, I met with them yesterday, and they've actually brought on a position, someone who used to work at Incita where I now work, who's actually going out and talking to GPs about brief interventions, because there is strong evidence that they work particularly in alcohol but not so much in other drugs. So it's an option that I think is underutilised. And I think the other thing is that many GPs aren't even aware of the guidelines themselves. A lot of people drink as well, and so there's all those bias that people bring to the conversation as well, thinking a few drinks a day. And then the previous data around the reductions in harm from drinking a small amount of alcohol around heart as well, I think is still... I think a lot of people still think that a couple of red wines a day are good for your health, whereas I think there's been some really solid evidence out there now to say that's actually not true. So I think we need to do a lot more around GPs and to understand that Medicare number and make sure they're using it a bit more. Yeah.
I'll just add that I believe there's no Medicare number for screening for other drug use. So again, GPs don't know how to answer the question. They don't even know how to bill for it. So, yeah.
Other questions? Thanks both for a terrific talk. My question, I was interested when you were talking about mid-strength or lower strength alcohol in venues, and with an 18-year-old son, I've seen the rise of the pre-drinks before hitting the city fairly late, when I don't think they purchase much because there is not the perceived need. So those kind of strategies and how they might be mitigated, I think, is a really interesting space. Just your thoughts on that? Yeah, I think you're right. I think that's something that we don't have enough of a handle on. I think it is definitely because drinks are more expensive in licensed venues and it's much cheaper to get it in the home. A lot of people are preloading, especially, as you said, younger people.
I think that is an issue that needs more attention. I know there is some research as well. There are certain venues that are problematic, and that's been found through one of our colleagues, Peter Miller's been doing some research nationally through an NHMRC grant where they look at alcohol presentations at emergency departments, and they ask 3 questions, and one of them is, where did you get your most recent drinks? And they're finding the venues that are tending to supply alcohol at really harmful levels, and then they're able to actually intervene with those venues as well. So that's a good strategy that we don't have in place in South Australia, but definitely preloading is a big problem. Yeah. And some products are really designed to catch kids as well and get them the way they're marketed and stuff as well, and they're quite cheap too.
So you're sort of talking about the reducing the stigma and the barriers to seeking help, particularly for other drug use. So how do you sort of balance that with ideas like the script checker or reviewing prescriptions of, you know, sort of opioid use and other controlled substances? So how do you balance those two ideas around it's okay, we just want you to make good and healthy choices and give you more opportunities, against we're also going to really extensively surveil your use, even if you're getting it from a medical professional or from a pharmacy?
Yeah, it's a really good question, Brianna. I think with that, it is about the kind of language we use to frame the issues and the kind of way that it's presented. I guess the thought would be if we can work at the level of things like GPs having more awareness and more support and understanding why people might be using, say, other drugs in the first place, say using not pharmaceuticals for non-pharmaceutical reasons, if that level of support can be there, then it's kind of the script check is kind of a level just above that to kind of monitor the use. I think there's also been concerns that some providers are over-prescribing, and so it's partly monitoring the prescribing practices as much as the individuals, kind of accessing those scripts as well. So it is a really tricky balance, though. It's trying to get that balance between getting people to seek help, like identifying there's a problem, but I suppose it's still trying to frame it as a health problem and saying we need these checks in place to kind of see it as a health issue. I think that's the way the experts were kind of really framing it, was about seeing it in that. Do you want to add?
The other one around pharmaceuticals and the misuse of them, it came out really strongly, is it happens a lot in rural and remote areas where there's just not enough access to treatment or other ways of dealing with pain, physiotherapists and a range of other services. So people are medicating instead of accessing services that might help them. So that's another issue that needs to be looked at.
Add one little point. It was also flagged by our experts that we're going to actually see more of that kind of use with an ageing population with other comorbidities. So physical pain that they're not seeking appropriate support or can't access it, GPs that aren't working out. So, yeah, it's just sort of another mechanism. Like, it wouldn't rely on that alone, I think. But, yeah, the idea that we'll see increasing trends with an ageing population is quite interesting, I think.
All right, any final question? No, well, thank you. That's a fascinating presentation again. Thank you very much. So please join me in thanking Jackie and Shona. So I think we're scheduled for a comfort break, comfort/coffee break. So we'll reconvene at 8. Thank you. everyone. What I'd like to introduce our next speaker. Our next speaker is Associate Professor Lynn Giles. Lynn's Associate Professor in Biostats in the school with research interests centred around the application of contemporary statistical techniques to life course data. Most of Lynn's research has primarily focused on the analysis of data from cohort studies, and in the past decade she's furthered her research interests that address how early life affects health in later childhood and beyond. So please join me in welcoming Lynn.
Thank you, Caroline. And thanks for the opportunity to be speaking here today. I'm going to talk about some work I've been involved with for the last few years and begin by acknowledging that we're meeting today on the lands of the Kaurna people, and I'd like to pay my respects to the traditional custodians of the land. So before I get underway, the work I'm talking about today is a collaboration with SA Health and with the Vaccinology and Immunology Research Trials Unit led by Helen Marshall. So lots of logos on the slide to reflect the different groups involved along with us. And the work I'm also talking about today is in press. Its publication online is imminent, but it didn't happen today, unfortunately. So this work will appear in Lancet Infectious Diseases hopefully this year, but please don't disseminate findings beyond this forum just while it's in press. So a little preview of what we've found. So I'm going to begin today with a tale of two diseases, and infectious diseases, unlike our first two communicable disease talks. So the first disease I'm going to touch on is invasive meningococcal disease, as our SA MEN-B immunisation program is targeted to really address. Now, invasive meningococcal disease, I'm sure you've seen cases reported in the media. It is a rare, fortunately, disease, but it has a really quite high case fatality rate, between 5 and 10% despite treatment, and can have devastating consequences for individuals who develop disease if they survive. The incidence peaks in children before the age of 5 years, before they start school, and there's another peak in adolescents aged 15 to 19 years, with the peak around 19 years. And somewhere between 5 and 10% of adolescents carry the bacterium, Neisseria meningitidis, in the throat, based on work in South Australia establishing the prevalence of carriage a couple of years ago. In South Australia, the most common serogroup of invasive meningococcal disease bacterium is serogroup B, and it's about half of all of the cases arise from that serogroup. But the other common serogroups in Australia are A, C, W and Y, with occasional cases arising from X. The second disease I'm going to talk about is gonorrhoea. Now, gonorrhoea has quite a low case fatality rate, but it's a major global public health problem. There's about 87 million new gonorrheal infections each year. And it has quite profound consequences for fertility via pelvic inflammatory disease, as well as some other complications. Alarmingly, in the Northern Territory, incidence is about 20% in some remote communities. So it is particularly problematic in that adolescent age group, 15 to 19 years, caused by the Neisseria gonorrhoeae bacterium. And WHO reports increasing multi-drug resistance, which is the main first-line therapy through antibiotics. There is no vaccine for gonorrhoea. Interestingly, Neisseria meningitidis, can't say that properly, so just bear with me, serogroup B and Neisseria gonorrhoeae are quite similar genetically. They share about 90% of the genome sequence identity. So while we think of gonorrhoea primarily as a sexually transmitted infection with consequences that present in the genitals, quite often it's asymptomatic, but it does also have consequences for sight, conjunctivitis, and a rash that's not as pronounced, but does share some features with the rash that quite typically presents when someone is developing meningococcal disease. So, against this background, over the past decade, vaccination has become an increasingly useful strategy in the fight against invasive meningococcal disease. And the UK was the first country to fund a public meningococcal B vaccine program. So that began 6 years ago. And vaccine effectiveness has been established for IMD in infants and in adolescents in different parts of the world, with effectiveness somewhere between 50 to 100%. So I've used purple blobs on this map to indicate where effectiveness for adolescents, vaccine effectiveness against IMD has been established in Australia and Canada, and in infants in 4 other parts. I hope my blobs haven't moved too much into the ocean, but you get the idea, hopefully. So the work in Australia, of course, was led from Adelaide, with Arta and others in the School of Public Health quite heavily involved in some of that work. The South Australian meningococcal B immunisation program began on the basis of some of that work on the 1st of October 2018. This was a 3-year 4C Men B, that's the GlaxoSmithKline product that particularly targets serogroup B. And it was a world first program in that it funded vaccination for children and adolescents, so children up to the age of 4 years. There's a bit of a convoluted schedule depending on when you were born, but the main strands are an infant and an adolescent program with some catch-up years for children in early childhood who were beyond the age of 1 year at the 1st of October 2018, and for adolescents when the program was implemented through schools at the start of 2019, there were some catch-up programs for those slightly older cohorts, as well as some coverage from the Men B part of its study in South Australia in 2017 and 18. So, on the basis of some work that has been around for a little while, as I said earlier, there's no effective vaccination for gonorrhea that's been developed to protect against infection with Neisseria gonorrhea. WHO has a global strategy to reduce gonorrhea by 90% by 2030. May be quite optimistic in the face of multi-drug resistance. Now, a tantalising idea has arisen in the literature over the past decade because the vaccines that are being developed against serogroup B, including 4C Men B, work in a particular way that may confer some protection against gonorrhea. There's ecological evidence from Cuba and from Norway and a case control study from New Zealand that showed following vaccination against IMD, or against Men B disease, there were some reductions in gonorrhea at a population level. So against this background, we are evaluating the South Australian Men B immunisation program. So that's led by the Virtue Unit at Women's and Children's Hospital and the University of Adelaide, and the School of Public Health. I've been involved with this evaluation since its beginning. And there's 2 main strands that we were asked to address by SA Health: to consider vaccine effectiveness and vaccine impact of 4C Men B against Men B disease, which is its primary target for vaccination, but also to consider vaccine effectiveness and vaccine impact of 4C Men B against gonorrhea in adolescents. So we drew on data from a couple of different sources for the evaluation. We looked at notifications data for IMD and for gonorrhea from the Communicable Disease Control Branch of SA Health, their notifiable diseases, and we considered 6 pre-program years, and the work I'm talking about today is the first 2 years post-introduction of the program. So 1st of October 2018 for the infant schedule, and 1st of February 2019 for the adolescents, because it's timed with the school year, administered through the school immunisation program providers. We drew data also from the Australian Immunisation Register, the National Australian Immunisation Register. Men B vaccination is not on that register, but vaccination against men A, C, W and Y is. So there is a national collection. And we also use population figures from the Australian Bureau of Statistics. There's more detail than I can go into in the time we have today, but more detail in our protocol that was published at the start of this year on the evaluation. So to look at vaccine impact, so trying to assess the overall impact on the population for men B disease, for each of the age cohorts, so the less than 1-year-olds, the 1 to 2-year-olds up to age 4, we compared cases in the 6 pre-program years to the 2 post-program years and calculated incidence rate ratios, and we adjusted for changes in incidence in the population that weren't vaccine eligible, fitted a Poisson model, and we also looked at predicting the number of cases from that fitted model without including data for the vaccine eligible cohorts to try and get an idea of how many cases we might have seen if it weren't for introduction of the program. And for gonorrhoea, we used a similar approach but a slightly different statistical model to take account of some of the properties of the data. Obviously, a lot more gonorrhoea cases we see each year than, fortunately, or unfortunately, depending on your viewpoint, but we see a lot more gonorrhoea cases than we do of IMD each year. So, of course, against all this, COVID happened partway through our evaluation. So there's a bit of an elephant in the room that I'll come back to. But of course, for a sexually transmitted infection, such as gonorrhoea, having sex is one of the main exposures that is necessary. And so we did see a slight dip in some sexually transmitted infections, but we also saw it in other STIs, and so that's our methodology does take some of that into account. So for vaccine effectiveness, we had a couple of different ways of estimating vaccine effectiveness against MenB disease for all programs, that is all age cohorts. We used 20 controls within an age window, a date of birth window, drawn from the Australian Immunisation Register, and a vaccine, the exposure was considered valid if it was received at least 14 days before the onset of disease so that there was sufficient time for the body to develop an appropriate immune response. Two methods for estimating vaccine effectiveness, the case control method and the screening method where we estimate the proportion of cases vaccinated out of the proportion of the population vaccinated, and all the details really given in our article, so I'm not going to go into it much here. I'm going to talk about our vaccine effectiveness against gonorrhoea because we had to use a slightly different method in this when we were thinking about controls. So we did again use controls from the immunisation register, but as I said before, exposure for a sexually transmitted infection, we really need to think about sexually active individuals. And so we also had controls who were those people in the same age group who were diagnosed with chlamydia. Another sexually transmitted infection, also can present asymptomatically quite commonly, and we thought that there would be similar sexual behavioural risks or protective practices in those two groups. For that comparison, we only took the first recorded diagnosis in our analysis for an individual for either gonorrhoea or chlamydia. And so those cases are included if they were eligible by age for the ongoing or the adolescent program that was on their school year or the catch-up program up to age 21. So to the results. So first of all, vaccine coverage is obviously quite critical, and as you might expect to see in a program introduced, so for children shown on the left-hand side of the pane, we see vaccine coverage now, it's running at about 95%. So it's matured since it was introduced 3 years ago. But we see children, so for infants there's a 3-dose schedule, and we're now seeing most children have had at least 2 doses by the time they are 1. For adolescents, the vaccine coverage is a little bit more difficult to give an overall summary for, but you'll see this peak in the right-hand part of the graph is for those who were in year 10, who were 15 to 16 years old between the 1st of February 2019 and the 31st of December 2019 in that main first year of the program. So that year 10 cohort we have the highest coverage for. In terms of impact against Men-B disease, 2 years after the program was introduced, so that is to the end of October 2020, we saw in infants a diminution in the incidence rate ratio to about 0.4 with a confidence interval of 0.23 to 0.69. And we saw 2 cases of IMD in that period. We would have expected about 5.2 cases if vaccination had not been introduced. For the subsequent children aged up to 4 years, we didn't see an effect. We couldn't calculate anything for 3-year-olds because it's a good thing there were no cases. So that's actually a reassuring result. In 15 to 18-year-olds, we saw some evidence of a reduction, but again, because it is such a rare disease, fortunately, we did not have a confidence interval that excluded one. Effectiveness against Men-B disease, so this is looking, this is a little bit more difficult to consider. There have been 2 cases in vaccinated children in the first 2 years of the program, one in a 2-year-old who had 1 dose of the vaccine in 2019 and another infant who had had 2 doses of the vaccine. We have collaborators in the UK who are looking at the specific antigen match for the vaccine, and that work suggests this second child's grouping was not one that would have been protected by the Men-B vaccine, but that will be in our publication looking at the 3 years of the program. Vaccine effectiveness for 2 doses of vaccine in vaccine-eligible children was close to 100%. So for the screening method and the case control method, those 2 different ways of estimating it, in children we saw figures around 94%. In adolescents, there were no Men-B cases in vaccinated adolescents and young adults, and so we have a vaccine effectiveness of 100%. It does look like the epidemiology of IMD is perhaps changing with earlier adolescents now emerging. So in terms of vaccine impact against gonorrhoea, we see in 15 to 17-year-olds, which is really that group for which we had the highest coverage in adolescents, we see an adjusted incidence rate ratio of about 0.76 with a confidence interval that includes 1, but an encouraging decrease. For 18 to 20-year-olds, there's not much evidence. Sexually transmitted infections have been steadily increasing over time in South Australia. There was a bit of a reduction, again, that elephant in the room, quite a big elephant, COVID. In the second year of our evaluation, we can see that there were decreases in adolescents, but that we again saw an uptick in gonorrheal infections in that year. So we're still not quite sure. Many of these individuals in the 18 to 20 cohort have some protection from the B part of it program that was introduced in 2017-18 when the evaluation of that earlier piece of work was carried out in South Australia. We really have been quite world first in a number of areas in this. Vaccine effectiveness against gonorrhoea. So when we consider the chlamydia controls, we find an effectiveness of about 34%, 35%. After we exclude those co-infections, so individuals who present with both gonorrhoea and chlamydia, so 2 silent STEs. So we're seeing vaccine effectiveness about a third. And using the air controls and the screening method, we find a higher vaccine effectiveness, but I think a number of those controls may not be sexually active, so may not be exposed. So we think that our result based on the chlamydia controls is probably the most informative. So to conclude, we've seen a reduction in Men-B incidence in vaccine-eligible infants, and there's some evidence of a reduction in adolescents. We have high vaccine effectiveness against Men-B disease in the vaccine-eligible cohorts. We did find some real-world evidence of cross-protection against gonorrhoea in adolescents and young adults. Now, a good thing for South Australia, perhaps not such a great thing when you're evaluating a program, is that the program is now ongoing. It was made as an ongoing program earlier last year. So that's terrific in that infants and adolescents in Year 10 are now offered Men-B vaccination as part of routine care. And importantly, our work can help, and programs like this can help to build trust in immunisation providers at a time when we know we need that. And it can also help to embed future programs. So at the moment, a pharmaceutical company, you might have heard of them, Pfizer, are developing a men ABCWY vaccine. So wouldn't that be fantastic if by the end of this decade we can offer a vaccine against the 5 most prevalent serogroups in Australia as part of a national program that may also confer benefits to protect young people against sexually transmitted infection, particularly gonorrhoea. So as part of this work, this is part of a large suite of work in this space in South Australia. So the next step with the evaluation of the SA program is to look at the cost effectiveness. The introduction of this program in many respects is relatively cheap compared to the profound consequences that individuals who are affected by IMD and their families and society face in terms of sequelae. So we're looking at that work over the next year with people from Oxford in partnership, building on some of the work they used in establishing the cost effectiveness for the UK program. We have an ongoing NHMRC partnership project with the NT government that commenced in 2019 to vaccinate in the Northern Territory to protect against both meningococcal B and to establish or to investigate whether there was evidence of its effect on gonorrhoea. That was supposed to kick off. We had a big launch campaign February 2020 to vaccinate young adults. So that's had some delays for some reasons, and it's also now trying to go in on the back of communities who've been vaccinated against COVID are really saying, I don't want any more injections, thanks anyway. So our project has been complicated, like many. We're also looking at a longer term follow-up in the NT with a great team of partners, James Ward in Queensland, so there's someone from every state and involved in this work to look at longer term 5-year protection. So we're using some interrupted time series, so some quite interesting methodology for that. And then I'll finish with some related work that we're doing in the School of Public Health. So this is really led by Adriana in conjunction with Helen and me. So Adriana's the first 3 here are looking at projects where she's interviewed close contacts to find out what happens on the ground when CDCB are interviewing and contact tracing, so how that's managed. Looking at the social networks of close contacts of IMD cases, which is some really interesting work that we're building with School of Maths and Associate Professor Lewis Mitchell. And then finally, Adriana's been looking at the spatio-temporal distribution of meningococcal disease and carriage in South Australia. So has 20 years of data, and that's some work that we've been undertaking with the Hugo Centre. And so spatially seeing on a map where those cases are and where the carriage is. And then some of Brianna's work, so Adriana, Helen and I are jointly supervising Brianna, who's done some great work this year that's now out in press, looking at guidance for public health management of IMD. Again, some work that's had some interruptions from that elephant in the room. And then finally finishing her MPhil looking at a systematic review addressing temporal changes in how outbreaks are managed for IMD around the world. So I'll finish on that. So lots in this space, an interesting, challenging space, rare but fascinating areas to find out more about. So think of all the other benefits of vaccination aside from against COVID. So I'll finish at that point. I hope I didn't go too over time. And I'll take questions. A question? Or question? How much time have I got?
Fantastic talk. Thank you, Lynn. Questions for Lynn? No? Well, we might. Well, I thought that was a fascinating talk, and congratulations on your impact as well. And I look forward to reading the paper too. So thank you. That was a fantastic. We might move on in the interest of time. Yeah, if that's all right. Lovely. Thank you. Well, we'll do a mic swap now. Thanks. All right. So our next presenter now. How are you for the mic? Yep. You happy to mic yourself up? Yeah, lovely. And we'll move your slides on. Yeah, how do we do that? Might need some help with that. Anyway, everyone else is better at that than me. So I'll stay out of the way. So our next speaker, our fourth presenter and our last speaker before lunch is Maha. Maha has just completed her PhD entitled The Role of Computer-Based Clinical Decision Support Systems in Improving Antibiotic Management, for which I understand she's received significant praise, so congratulations. Maha's research is focused on the assessment of the feasibility and sustainability of electronic decision support tools for evidence-based decision making. So over to you.
Hi everyone, my name is Maha and today I will be presenting an overview of the research that I have done as a part of my PhD. The topic of my presentation today is clinical decision support systems for antibiotic management and what are the factors that are limiting the sustainable digital health transformation. Antibiotic resistance is a significant public health challenge due to significant clinical and economic burden associated with it. Many studies have attributed the increasing antibiotic resistance to inappropriate and excessive use of antibiotics. In Australia, it was estimated that approximately 50% of the antibiotic prescribed in community settings, whereas approximately 23% prescribed in hospitals are either inappropriate or prescribed but not required. Many studies or the efforts targeted at reducing this excessive or inappropriate use of antibiotics highlight the importance of access to timely information for evidence-based decision making. But then this information is based on multiple streams of information which make it quite complex to integrate in practice at point of care. Fortunately, digital health systems such as clinical decision support systems provide a solution for this complexity. So what is CDSS and why do we need it? Clinical decision support systems, also known as CDSS, are a kind of a medical software which integrate patient-specific information from electronic health records with the evidence base or knowledge base. This knowledge base can be medical literature or practice-based evidence. So using this information, these systems provide recommendations for diagnosis or treatment based on patient-specific risk factors. Therefore, not only allowing evidence-based decision-making, but also personalized care. These systems, CDSS systems, are becoming critical for the healthcare because the tremendous increase in the volume of the clinical data. It is estimated that there is a time lag of 17 years in translating only 14% of the research data into clinical practice. Now, despite the benefits of many digital systems such as CDSS in literature, the adoption or use of these systems in practice is still very limited. These systems provide the benefits of reducing medication errors and enabling evidence-based decision-making, but use and adoption cannot be achieved to a maximum extent. And this is specifically related to the complexity of these systems. As shown in the diagram here, these are quite complex systems which are then implemented in a complex healthcare environment, which is characterized by the interaction of the technology, people, and processes, which make it quite complex. Due to this, we still don't know how can these systems be implemented optimally to achieve their benefits. Working on this research gap, the overall aim of my research was to identify the implementation barriers, including at different levels, organizational, individual, and then healthcare system level, to identify what are the barriers of non-adoption of CDSS. For this purpose, I adopted a mixed method study design comprising of 3 studies. In the study 1, which was a systematic review and meta-analysis, we tried to understand what is the impact of CDSS on overall antibiotic management. Whereas in study 2, we tried to identify what are the factors that influence the use of these systems by healthcare practitioners. And then in study 3, we took more broader perspective and tried to understand what are the factors that limit the integration of digital health tools in a healthcare system. I'll discuss the results one by one. So the study 1 focused on a research question whether these systems deliver any value for antibiotic management. For this purpose, systematic review and meta-analysis was conducted. The review protocol is shown here. These studies were selected on the basis of specific PICO question. I included the evidence both from the randomized and non-randomized trial, but because of the nature of intervention, there were not many randomized trials in this field. The studies were critically appraised using different risk of bias tool, and finally meta-analysis was conducted. This is the PRISMA flow chart for the selection of the studies, starting from 6,410 studies identified from the literature. After selection and on the basis of PICO question, overall 57 studies were finally included. One of the main outcomes of the meta-analysis was actually the appropriateness of therapy. The included study defined antibiotic therapy to be appropriate if it complies with the guidelines or in vitro susceptibility test results. Total 21 studies provided data for the meta-analysis, of which only 2 were randomized trials. The overall principal finding of the meta-analysis indicated that the prescription made using CDSS were twice as likely to be appropriate as compared to the standard care or the prescription made without using CDSS. The comparison of the effect across different study design indicated that non-randomized studies, due to inherent study biases, do overestimate the effect. Although the magnitude of effect or the extent of the effect varies across different study design, the direction was largely consistent, which is supporting the positive impact of CDSS. Another important finding here is substantial statistical heterogeneity that I have observed in my results. Many studies indicated that one of the factors that might be contributing to this variability in results is actually the variability in adoption of these systems across different studies. And I'll discuss this in the subsequent study. For other clinical and economic outcomes that I have included in my systematic review, studies reported results in different units, which make it very difficult to pool results. Therefore, we do the narrative analysis. The graph here shown the results of the narrative analysis. The green graph shows actually the decrease in outcomes, whereas the red bars show the increase in outcomes. After the implementation of CDSS, many studies reported decrease in outcomes such as volume of antibiotic use and length of therapy or duration of therapy, which eventually leads to more optimal treatment after the implementation of CDSS. But one important factor here is that due to the change or the reduction in the antibiotic therapy, it can lead to elevated health risk, specifically for immunocompromised population. Therefore, many studies relied on outcomes such as mortality or length of hospital stay as a safety of measure. There was a relative reduction in these outcomes, which indicate that not only the quality of care is improved after the implementation of care, but also the safety of care. As I was discussing before, that there was a large variability in results. Some study reported good positive results, while other studies are unable to identify any impact. So it warrants further investigation that why studies have such a variability in results. So for this purpose, I studied, carried out a study too, which actually identifies different factors which relates to the factors which then impact clinicians' ability to use or adopt CDSS. For this purpose, a cross-sectional study was conducted in which an online survey was conducted with the healthcare workforce across Australia. This study was based on a theoretical framework, which is shown here. Without going into much detail of this theoretical framework, this theory actually provides the different factors which influence the user adoption behavior. One of the important factors of this theory was the moderating variable. The theory indicates that there are certain moderating variables such as age, gender, which directly influence the adoption behavior. To understand this further, I carried out inferential analysis to understand how these moderating variables are associated with users' behavior to adopt CDSS. These are the results that we have achieved from this study. The 4 basic barriers that participants indicated are shown here. 69% of the participants believed that the lack of training or technical support in the organization limits the use of CDSS. Similarly, 64% believed that the lack of trust and confidence in the recommendation provided by the system also negatively impacts the use of these systems. Similarly, time constraint was also an important barrier. And finally, 48% believe that the risk of limiting their own professional autonomy in clinical decision-making negatively impacts the use of these systems. Interestingly, the clinician's year of experience was an important moderating variable. As clinicians who had higher clinical experience, specifically in our sample greater than 11 years, were more likely to think that use of CDSS with compromise their professional autonomy in decision making. This might be related to the fact that these clinicians have established practices and they tend to trust their own clinical judgment rather than recommendation provided by the system when they don't know how these systems came up with these recommendations. Similarly, there was also a difference of opinion in different settings. For example, clinicians from the primary care were more likely to think that the time constraints in primary care directly impacts the use of systems. Increasing workload and limited time in a standard care might be contributing to this. Similarly, in our sample, many negative perceptions such as limiting professional autonomy or lack of trust were more common in non-users as compared to users. This might be related to the fact that the users are usually, early users are the digitally able clinicians who have more trust in the system, and then there is a lack of communication for the wider healthcare workforce who still do not trust the systems. As these findings relate to more organizational or individual specific factors, there is still not very clear how can complex interventions can be introduced in a healthcare system, which is characterized by the interaction of technology, organizations, and individuals. Therefore, we took a more broader perspective to understand how can digital health systems be introduced across organizations for an effective and a coordinated care. For this purpose, we carried out interviews with different experts and policymakers who are directly involved in different digital health activities in Australia. These are the 3 main themes that we have identified. The first theme was data standards. The value of any digital health system, specifically CDSS, to coordinate care is not limited to its technical sophistication, but it relates to how it communicates data and transfer data between different systems and different organizations. Unfortunately, participants indicated in our study that in Australia, that different digital health systems are implemented as a standalone applications, due to which it limits the ability of clinicians to access the different data generated across different organizations. we still don't have any data standards which ensure that data flow between different organizations without compromising its meaning and context. One of the important factors that we identified is that Australian digital health landscape is characterized by the loosely connected data sets and organizations which do not have the ability to transfer and share the data in a standardized format. Therefore, there is a need to develop a mutually agreed data standards through which organizations can generate and transfer health data across different organizations, across different states. While we are talking about the data standardization, it is also important to remember that CDSS implementation is a complex process which requires the interaction between different technical factors, organizational factors, and individual practices. And then it relates back to the finding that I was discussing in the previous study, that different individuals in different settings may respond differently to the same systems. Therefore, there is a need to understand local context, local requirements. The implementation policies that many participants have experienced in Australia is based on a one-size-fits-all strategy. This top-down or forced implementation conflicts with the clinical culture. Therefore, it leads to more pushbacks and resistance against the systems. The implementation strategies where needs to standardize the data flow also needs to take into consideration the local requirements and local context of different individuals working in a very complex environment. And the last is digital health literacy. Participants believe that the ability of any organization to implement and then sustain systems such as CDSS is directly linked to the end user's ability to use the system effectively. But currently, without paying attention to the digital health literacy, the implementation of many digital systems are actually propagating the disparities in health workforce in accessing the information. Currently, there is no framework in Australia to equip the workforce with a dual skill set, including both clinical as well as digital skill set. Due to which, some clinicians who are younger and are more digitally able are accessing these systems, but experienced or senior clinicians are more likely to push back or resist the systems. Now, finally, summarizing all these findings, our study indicated that CDSS do have the ability to improve the evidence-based decision-making, specifically for antibiotic management. It increased the compliance with guidelines and reduced the excessive antibiotic prescriptions. However, these results cannot be translated into practice if contextual findings is not taken into consideration. How different individuals in different settings respond to these systems. In this regard, factors such as end user skills, communication, workflow dynamics are important factors to consider. In system-wide, where different organizations interact with each other, it is very important to understand how different individuals and different factors came together to bring a more collaborative care models, which must be involved along all the phases of CDSS implementation to provide a plan which understands the interaction between the technology, processes, and the individuals. Thank you. At the end of my presentation, I would like to thank my supervisory panel, Professor Tracy, Dr. Adriana, and Dr. Drew for their guidance and help throughout my PhD, and also different organizations and participants who provided us the useful data. And thank you for listening for my presentation. If you have any questions or suggestions, I'll be happy to take it. Thank you.
Great presentation and really important work. Thank you very much. Questions for Maha?
Thanks, Maha. That was really interesting to see the difference between policy seeping down into clinical practice. I'm curious to know, how were these kinds of digital technologies and system interfaces introduced into a clinical practice? How were people made aware of them and encouraged to use them? Did you get any kind of sense of how that went and what kind of strategies might work better than perhaps ones that didn't work so well?
Yeah, so as I was discussing that, one of the important factors that I have identified in my studies is that the implementation strategies right now is usually one size fit all or top down, forced implementation, that this is the digital system, go ahead, use it. There is no system to develop trust and confidence in a workforce which are used to with the certain practices they have been doing. So for them to trust any other system which they are not used to and they have to learn how to use it, it is very important to establish a trust and confidence in the practice. That is why collaborative care models which involves the different stakeholders, healthcare practitioners, industry, evaluators, and they all come together to actually identify that how to introduce these systems into a healthcare systems, which is about all the integration of all these different elements. So one of the major factors that is contributing to the pushbacks is that clinicians don't trust these systems because somebody else is telling them this is the system for you to use. Even if you don't trust the system, just use it. So the important point here is to establish the trust and confidence and communicate that why these systems are working. Like why the recommendation provided with the system will help you evidence-based decision making. So more about the advocacies and confidence building.
Very interesting research and an excellent presentation. Thank you. Given that you found that ego is essentially the biggest barrier here, a tough crowd to get on board, my curiosity is a sort of a step back, perhaps a stupid question, but who and how was this decision support system designed? By whom and with what buy-in? Are there versions of updates that could include some of the recalcitrant idea to get on board? And secondarily to that, if an intervention is the next step, who's your target audience for change and uptake?
Because in this study I have tried to understand the barriers from different perspectives. I have not just targeted on the end users, healthcare practitioners, understand what their problems are, but I try to understand the problem from different perspectives, from the organizational, individual, and then policymakers. The purpose was to to have a more holistic understanding of the problem. So the finding of my research is that the problem doesn't lie in one sector. It's not about only the healthcare practitioners not trusting the system. It's about policymakers not understanding that the digital health implementation is not about introducing a technology in the health sector. It extends to reconfiguring the processes and policies to understand how can existing structures and existing policies can support the innovation. So understanding that's why the recommendations I have provided doesn't only targeted just the policymakers. I have provided the recommendations in my research for healthcare practitioners, highlighting why they need to have a better digital health skills. Similarly, for policymakers, how can the policies or processes can be reconfigured to the innovation. Similarly, for the evaluators, which is the next step that I'm doing in my research, to communicate the safety and quality of these systems. Because without communicating the safety and quality of the system, it's not possible to increase the confidence and trust. So it's kind of more holistic approach rather than one group.
Thank you, Malika, for such a great presentation. And I think your topic of research is very useful and practical. So how could we disseminate such an important findings to different target audiences? So this is building upon the last question, because apart from publishing in a paper, we need to have specific tools. So are there any thoughts?
Thank you for that suggestion. Of course, again, so when I thought about publishing my research, I have taken into consideration the scope of that study and what should be the audience of that. So, for example, some studies which were more Australian health system specific, I try to target the audience which is more Australian oriented, like journals which are more read by the Australian, you can say, population. So it's not only about the publication of these research through conferences. I'm also trying to disseminate these findings. But yes, as you are saying, that these are not about the publication, but they should be the policies. So the different policymakers that I have specifically interviewed for my last studies, they were really interested what are the outcomes of my studies. So one step would be, which I will going to do, is like provide them the summary of the finding and the suggestion and that recommendations that came out of. And because those participants were directly involved in different digital health projects, so I think so it will be very relevant and it will provide them good recommendation on the basis of the evidence.
Great, thank you very much. Well, thank you. Please join me again in thanking Maha for her presentation.
Thank you so much.
Thank you. So we've had 5 excellent presentations this morning. Thank you very much. Lunch is now ready and we will reconvene at roughly 12:45. So thanks very much, everyone.
Hopefully there are people there on the other end of that live stream. Yep. Thank you for coming back after our lunch, and I'm sure that most of you, like me, looked at the soft drink and the chocolate brownie and thought perhaps I shouldn't be having this. But anyway, it was very nice. So I'm Tracy Merlin. I'm the Professor and Interim Head of the School of Public Health. And it's my great pleasure today to announce the recipients for our scholarships and prizes that have been recently awarded by the school. So to start with, I'd like to talk about our first award. So this was established in 2017 by Emeritus Professor Philip Ryan, and it is the Philip Ryan Doctoral Candidate Travel Grant. It's a grant of up to $5,000 that supports PhD research students to present papers at international conferences or a main conference held in Australia by an international organisation. It's awarded annually to an enrolled PhD student of the School of Public Health who has completed the equivalent of at least 2 years of full-time candidature. Please, Phil, would you like to come up and present the award, please? So this year, and I hope everybody, our recipients are here, but we're pleased to award the 2020 Philip Ryan Doctoral Travel Grant to Alexander Proctor. We have a live one. Oh, that's good.
Thank you very much. Thank you.
Thank you, Phil. And we might need to, have we got a camera or anything? We might need to get some photos. You got enough on your plate? You were too slow for it? Can you do it out when we get out? Yeah. Okay. So yeah, Alexander Proctor. I forgot to hit the thing.
Our next recipient actually hasn't come back from lunch.
Really?
Yeah, I don't know where they've managed to. Anyway.
Do we want to? What about the other one?
Yeah. Fine to go with them. If you want to go with Teresa's first.
We'll go with Teresa's and we'll come back for Neville Hicks' one. So I'll just skip across. Apologies for this. We're always... All right, you've got a heads up on who's won. So we'll move to our next award. This year was challenging in many ways as a head of school. But the most challenging and distressing event was the loss of a friend. And our much-loved colleague, Teresa Burgess. Teresa passed away this year from a short and devastating illness. And our loss was deeply felt, but for her family it must have been unimaginable. And Teresa's husband, Greg, and sons, Stefan and Nicholas, are here today to honour Teresa's memory. So as a way of recognising the impact of Teresa on those around her, staff in the school and colleagues, friends and family have come together to set up a student prize. And this is the Dr. Teresa Burgess Memorial Prize in Public Health. Now, the prize will be awarded annually, and it reflects values that we know Teresa held and which reflect her care for her students, her service to the school, and her relationship with colleagues. So, we're going to be a fine pair today. The prize is awarded to a candidate that has consistently demonstrated the values of selflessness, helplessness, care, helpfulness, I should say, care, responsibility and integrity in their dealings with peers in public health. The candidate must have demonstrated service of significant merit to others in their class, the school or the community in public health, and students are nominated by course or program coordinators of public health courses or degrees. The recipient of the inaugural 2020 Dr. Teresa Burgess Memorial Prize to Public Health has consistently demonstrated support and thoughtfulness to her peers, including in tutorials and in online environments, conscientiously shared additional topic-relevant resources that she's found with her fellow students and with her teachers, and is an enthusiastic and committed undergraduate student representative on the School of Public Health Programs Board. One staff member also said she's also a lovely and humble person with an openness and enthusiasm for learning that reminds me of Teresa. So it's with great pleasure that I can announce, and if Greg would like to come up. You got it. I'd like to announce the inaugural 2021 Dr. Teresa Burgess Student Prize goes to Lara Stollery. That's all right. Taught it. So thank you to, I'd like to thank the staff who helped me to judge that award as well, and to thank all of our selection panels for our awards. It's a difficult task, and we have very many fine students that can help. Now we're going to skip briefly. We can go back to the other one. So, and which you've already seen. There. We have been very blessed with support from Pamela Ball and Alison Greenslade, who are family, or Pamela's partner and family of Neville Hicks, who was with us for many years, had a massive role in the school and led us for quite a period. It was this scholarship was first awarded in 2018. It is the Neville Darrington Hicks PhD Scholarship in Public Health Policy, and as I said, was initiated by Pamela and Neville's daughter Alison Greenslade. It's a $5,000 scholarship, and it's provided to contribute to the education of PhD scholars in public health policy development. Now, Pamela, you wanted to speak?
Yes, I'll just say a few words.
No. Do you want to put that in?
Where do you? We'll just you can put it in the right spot.
We'll try. There you go.
Well, it's a pleasure to be here once again. Now that since 2018, it's becoming quite a few years. I represent Neville Hicks, and he can't be here because he is a very long-term victim of Alzheimer's disease. I'd like to thank the school for inviting me to take part, and I extend my thanks to Dr. Jane Harford, Professor Tracy Merlin, and Associate Professor Sharon Gaskin for their roles in the selection committee. Well, Neville, formerly reader in public health at this university, was known for his leadership in the field and recognised here and overseas for his research and teaching. His focus on public health and ethics moved seamlessly from the local to the national to the global. In setting up the scholarship, we've honoured his long-held pre-dementia plan to give financial support to postgraduate research on topics with significance to the health of populations now and in the future. Well, as the years pass, the memory of Neville as a lively and engaging teacher, that's him up there, is fading. It's quite a long time ago now. And given his present health status, it can be seen as both ironic and comforting that there's a whole cohort of former students out there who engaged with his carefully researched and considered ideas on ageing, on aged care, and even included the ethics of dealing with dementia. So now, back to the scholarship. In the judgment of the selection panel, the outstanding candidate for this year's scholarship is Shagufta Praveen. Oh, I'd better give it to you, hadn't I? Thank you very much.
Thank you.
You can stand. Oh, we have to be photographed. Oh. Thank you. Just a little bit about Shagufta's research. Her topic is the application of primary health care principles in national or large-scale community health worker programs in low and middle income countries. In her three-part research program, Shagufta is clearly fulfilling the spirit of the scholarship in applying public health policy to the establishment of principles and criteria for seeking better healthcare outcomes on a global scale. We wish Shagufta all the best in her future research, and we hope that this small scholarship will make some contribution to the expenses that she's incurring in her international study. So thank you.
Thanks so much, Pam.
Thank you.
Once again. Thank you.
Okay, back, we'll skip forward again. Oh, we don't have it there. Our next presentation is the Dr. Teresa Burgess Oration. And we decided as a school that it would be important to continue on with the research that Teresa has done or has been involved in, and also to recognise that area of research, which was in primary healthcare, health services and systems, health policy, and most recently, end-of-life care. Teresa was a passionate advocate for independence and dignity at the end of life. She completed her PhD in 2016 on the topic of chronic disease management along the continuum of care, the role of the health system in supporting people with end-stage chronic illness. It was a mixed methods study. Teresa was a very good qualitative researcher. And it was looking at health systems policy, practice, and the experiences of individuals as they approach the end of their life. More recently, she worked on research exploring end-of-life care and advanced care planning in vulnerable communities in the context of public policy making. So I'm pleased to introduce the inaugural Dr. Teresa Burgess Orator, Associate Professor Jacqueline Eliott, Jacqueline worked very closely with Teresa for a number of years. Jacqueline employs qualitative methodologies as well to examine how people talk or write about their experience and perceptions of health-related issues, with particular reference to the social and ethical implications of different ways of understanding for individuals, carers, and society in general. And she's particularly interested in the intersections of private, public health and medical ethics in healthcare. Jacqueline is the higher degree by research, you can come, postgraduate program coordinator in the school, and was most recently the program coordinator for the postgraduate coursework degrees in counselling and psychotherapy. So let's find your presentation.
Thank you, everyone. I'm here to talk on behalf of Teresa's colleagues and friends here at the School of Public Health. I'd like to begin with acknowledgement of country, to pay our respects to the Kaurna people, the traditional custodians of the land on which the Adelaide University is built, to acknowledge the deep feelings of attachment that the Kaurna people have to country, and to respect and value their past, present, and ongoing connection to the land and cultural beliefs. Always was, always will be. We're here today to honour the memory of our dear friend and colleague, Dr. Teresa Burgess, and I'm honoured and humbled to have the privilege of speaking at this, the inaugural oration launching the scholarship created by friends, family and colleagues, in memory and thanks for who Teresa was and for the legacy that she left us. It is incomprehensible to believe that it's only been 6 months yesterday since she left us. I did not know Teresa as well or as long as many of you present here, and others have spoken eloquently about Teresa as a private friend and family member. Many of us were present at her memorial service to say farewell and celebrate her life in late June. What I want to do today is to share some of her research, and through this to remind ourselves of what matters in what she did and what matters in what we do in public health. After training as a nurse at the Royal Prince Alfred Hospital in Sydney, Teresa did a graduate diploma in nursing management, and then, lucky for us, she moved to South Australia. She completed her Master of Primary Healthcare at Flinders, receiving a Chancellor's Commendation for that. And moving to Adelaide, she completed a graduate certificate in higher education, which surprisingly is not that common in university educators, and I think is testament to the passion that she had for being the best that she could be in whatever field she was in. She also completed her PhD at the University of Adelaide, as Tracy shared with us. She began her career here at the University of Adelaide in the Department of General Practice and became an integral member of our community across so many areas, but always remembering the names and positions of everyone she ever met. If you wanted to know something, you would ask Teresa who can help, and she would know who they were, where to find them, and actually help you link up with them. Reflecting her focus on Indigenous health outcomes, she most recently contributed to the health promotion and best practice and capacity strengthening within CREATE, the Centre for Research Excellence in Aboriginal Chronic Disease, Knowledge, Translation and Exchange. Her public service reflected Teresa's deep commitment to public health and more vulnerable members of our community. And I want to share some words here from Adrian Hurd and Chris Morris, who are part of the SA branch of Public Health Association of Australia that Teresa was a part of. They said, Teresa was one of the longest serving members and was an active and dedicated committee member. She played an important role in setting up the mentorship program in the SA branch and the model used in SA. went on to be used nationally and is still a core program today. What Teresa did stuck. She made a huge contribution to public health in SA through her teaching and research. Her dedication to research activities that included vulnerable populations and the ethics of health technology, and I'll be talking more about both of those later, were testament to her concern for the social determinants of health and the impact of those on our more vulnerable members of society. She was also a founding member of GriefLink. GriefLink is an online site that provides information for people dealing with the grief caused by the death of someone close to them and for those who are supporting them. Mary Brooksbank, the current chair and long-term friend and colleague of Teresa, said this: Teresa has long been passionate about supporting those facing death, both in her research and service to community. She was a founding member of GriefLink in 1998-99 and stood as secretary for many years until she stepped down at the start of this year. She was always organised and diligent in this role, prepared to go the extra mile, warm, open and unceasing in her commitment to improving the accessibility of resources for those dealing with loss and grief. Her contribution has been recognised through the NHMRC as an outstanding external assessor and recently with the Basil Hetzel Leadership Award. I want to talk a little bit about Teresa's dissertation, which Tracy mentioned earlier. It examined the healthcare system as it operates for people with chronic disease as they approach the end of their lives, using a systems thinking framework to map the complexity of care provision. It comprised a national state policy audit, which identified policies related to chronic disease and palliative care intersect, or maybe don't intersect, to facilitate end-of-life service provision. A 360-degree review through qualitative interviews with 9 patients, 6 carers and 10 key service providers to examine health, system functioning and access to care. Conducting and analysing interviews with 12 service managers and policymakers to explore their perceptions of system functioning and the changes required to make the system function more effectively. And finally, she synthesised those results using a complexity theory framework to understand why the system functions the way that it does, and most importantly, to identify appropriate places to intervene to bring about changes that were needed to improve the care and experience of people at the end of their lives. And what did she report? Well, Australian policymakers had not, and sadly still have not, developed effective policies for end-of-life care models for people with chronic disease. There are few intersections between chronic disease and palliative care, and people often fall through the gaps. There's inefficient attention to the need for continuity of care from one location, from one stage to another, and the end-of-life needs for those with life-limiting chronic diseases. And this care needed includes practical, medical, psychosocial and emotional support. Despite a decade of healthcare system advocacy for integrated care, care silos still remain. And advanced care planning remains uncommon in chronic disease care, despite the fact that we know that the number of those diagnosed with chronic diseases is predicted to go up. Clinicians still feel uncomfortable raising this topic. So not surprisingly, looking at this whole of public health systems approach, Teresa made a number of recommendations. Firstly, that we needed to change the culture and attitudes around end-of-life care, to take a whole of systems, a multidisciplinary integrated model, to develop a shared vision of what end-of-life care in chronic disease should look like. And Teresa called for a reform of the structure and funding of primary care and the provision of incentives for quality end-of-life care. Now, as postgraduate coordinator, I've seen an awful lot of theses across my path, and I can tell you that this is an amazingly comprehensive and highly rigorous body of work. In fact, this is what Annette Brannock-Meyer, one of her supervisors, said about Teresa's work. In both her own research and her supervision of others' research, Teresa combined rigorous scholarship with a sincere desire to make a difference, and just as importantly, care and compassion. This is a rare combination. While she was doing her PhD, she was also a senior lecturer here at the School of Public Health across so many different domains, touching the lives of many students. One of these, Cameron Scott, shared this. Teresa's effort, expertise and caring towards me continues to influence my work practice, my interactions with colleagues and people in the community today. I continue to use the skills that she fostered. She was unwavering in her support. Again, from Adrian Hurd and Chris Morris, they said that Teresa was a wonderful teacher. The warmth and generosity with which she approached her students and their learning was wonderful to experience. They fondly remember attending her public health courses as a guest lecturer, and her students clearly loved her. She made public health come to life with her knowledge and passion. Following conferral of her PhD, Teresa supervised Jasmine Gregory in her Master of Philosophy. This is what Jasmine shared about her experiences. I was extremely blessed to have known Teresa Burgess, who is a beautiful soul. Teresa was my supervisor, supporting me to complete a Master of Philosophy with a focus on Aboriginal women and strength and resilience. Teresa's humble and soft nature enabled me to quickly build a trusting relationship with her based on genuine love and respect. Teresa travelled to Geraldton, WA, which is where she lives, and met my family, and we worked from my home. I loved the visits. Our conversations over time led to discussions about family and the world, and always we would have laughs and some humour mixed in. Teresa would email me and ring in between, reviewing documents, giving me feedback, and I loved that about her, always caring and wanting and hoping to produce the best. Teresa had a genuine interest and curiosity in Aboriginal people and communities, and in the areas we researched, I felt her learn as much from me during this time as I was learning from her. She was a gifted academic and researcher, and this research is part of her legacy, and I will be forever thankful to her for it. I lost my dear friend, and the world lost an angel. Teresa Burgess, loved and never forgotten. Teresa's grants demonstrate her continued focus and commitment to the vulnerable on inclusivity and equity and a systems approach to making change. She was able to see and value the micro of the interpersonal interaction and the need to address the macro at a systems and policy level. Teresa was and still is publishing, and her extensive number of co-authors shows the diversity of interests and just how much you wanted to work with Teresa. If you had Teresa on your team, you knew you had someone who was going to do the work she committed to doing, and she was going to do it, excuse me swearing, bloody well. I want to take you on a whistle-stop tour of Teresa's published work, drawing out some key themes and providing some examples of her work. Her primary focus was here. Catherine Hodgetts, who's worked closely with Teresa since about 2014, has said, "I've been inspired by Teresa's hard work, collegial generosity and support, respectful, dedicated approach to community participants and partners, intellectual curiosity, and a genuine commitment to support public health outcomes for all South Australians, especially those whose voices are seldom heard within a policy-making process." And these are just some examples. But echoing the sentiments expressed in her thesis, Teresa knew that a public health approach needed to also address healthcare systems and policies. Colleague, supervisor and friend Gregory Crawford said, "Teresa had a long and quiet commitment. She was a fierce advocate and actively participated academically, but also in community organisations to further this work. Some examples. And somewhere in the middle of those, or at the centre of those, is clinical practice. Teresa knew that we had to work with clinicians to keep what worked, to value what worked, and to seek opportunities to identify moments for change, for improvement. And finally, Teresa was committed to teaching and educating emerging clinicians, public health advocates, and researchers. Greg again said that Teresa epitomises the fully rounded, complete academic. She was never one to blow her own trumpet, but always keen to pass on her knowledge to many. She was a passionate educator. At meetings, she contributed with strategic insight and compassion and sought opportunities to include, to upskill, to support and celebrate those around her. Let us remember Teresa Burgess as a passionate, committed academic at the peak of her career. Teresa brought a depth of compassionate... Oh, sorry, here's my examples. And with all of these, it was hard to separate them into the areas because they really fed across all of those different areas. Teresa brought a depth of compassionate, rigorous scholarship spanning all these and exemplified the best of public health research. I want to now share some findings, some published, some yet to be published, of projects that she led and which continue today. I remember attending a university-organised meeting with academic researchers, government and non-government representatives and technology designers talking about smart technologies and what they might do for us as we aged. Afterwards, we shared our dismay that the voices of those older persons who were less privileged than those representing these organisations was very absent. And it's typical of Teresa that she actually went on to do something about that. She proposed this project in April 2019, asking, how can we design and implement new technologies that address the needs of older people and enable them to age in place in ways that are socially, ethically, and economically acceptable? Her ideas contributed to a pilot study for the Office of the Ageing, including these people here. And Jackie Street, one of these investigators, told me that Teresa led most of the empirical research. And I know that's true because I've looked at the report, and at the end, under every participation information sheet, it says, for more information, contact Teresa. She also contributed to these World Cafes, which were held in 3 locations. These allowed older people to hear about and then discuss some examples of smart technologies that may influence how we live in the future. She knew and valued the perspectives that these older people would bring to this space. The think tank included representatives from eHomecare, ACH, the Global Centre for Modern Ageing, Coda SA, My Home Care, Seven Oaks Retirement Village, Rest Haven, Elder Care, Uniting Communities, and the Centre for Creative Health. And it is again testament to Teresa's ability to bring people in that she was able to have all of those present. Following submission of this report to OFTA, the study was reproduced in Wollongong, and I want to share some of the findings from this study. So 41 participants in the 3 sites were recruited through local council, e-newsletters and other mechanisms. One was in Adelaide's southern suburbs, another in the northern, and one in regional area of Port Pirie. And these locations were deliberately chosen for their socioeconomic profiles and given assumed connectivity issues that might be experienced in regional and remote areas. They watched short videos about smart technologies and then attended tables for discussions focused on one with these particular set of questions to facilitate discussions. Some of the results that came from this study. Regarding autonomous vehicles, participants were surprisingly in support of these, particularly as they thought it would enable them to maintain independence and autonomy, and especially for the men, that was really important, particularly given a likelihood of losing your licence at some point as you aged. It was also seen to reduce car accidents, which may be more prevalent as you become less able, and in turn reduce the call on medical resourcing and reduce pollution. However, they did come up with some negatives, and these centred around a potential loss of human contact. They actually valued talking to the driver of whoever was driving if it wasn't them. They worried about how you would pay for these things, and were worried that people might lose jobs if they were replaced by autonomous cars. They also worried about how would this work in rural areas where it's difficult to get perhaps accessibility to such new technologies. Talking about robotics, they were surprisingly, this little robot you can see was an example that they were shown, a robot with a bit of a smiley face on it, handing things to them. And they were surprisingly positive about this as well, particularly for assistance with personal care, where they felt it might be less embarrassing to have a robot assist them with some personal care items than a human being. They also saw potential for alleviating loneliness, not only in interacting with the robot, which could talk and interact, but also enabling them to connect readily with other people in their social network. However, again, the negatives centred around potential loss of human contact. They were also worried that they might get a bit lazy if the robot was doing everything for them, and they get less physically active and perhaps start to lose their marbles because they wouldn't have to think so much, which was kind of cute. They worried about the cost of owning and accessibility for perhaps people who weren't so financially well off and who would maintain it when it would inevitably go wrong. They worried about security, who might have access to the data that it would have, and again the loss of jobs, that this shouldn't replace the people who might be able to provide human social contact. Smart homes, they were quite positive about, considering that they would provide increased safety. They might remind you to turn off the stove if you'd absent-mindedly left it on. I could do with that. They might also increase their ability to stay in their own homes for longer and rather than go to a residential aged care, and that was viewed very, very positively. It might also give the opportunity to alert people if there had been no movement in particular areas of the house that are normally seen, so that people might be alerted to perhaps an accident. Again, there were negatives. They worried about, and I share the concern, difficulty in learning new skills and feeling overwhelmed with the new technologies and things that you have to learn to operate them. They were worried about accessibility for people who were renting, how easy it would be to have those sorts of things made available. I found the acronyms that are used with new techs very frustrating. Hands up if you feel the same way. And again, worried about potential loss of connectedness. They valued the opportunity for neighbours to actually check in on you, and worried that if that was seen to be being done externally, that perhaps people wouldn't check on you and lose that sense of connectivity to your social neighbours. And of course they worried about who got to see their data, both intended use and perhaps incidental or accidental breach of privacies. Wearables, they were positive about because of an increased sense of security, that if they had a health event that somebody would be alerted to that and be able to attend to them. Again, it gave them increased confidence about staying in their own home and feeling able to get out of the house, knowing that there was something there that would alert someone if they had a fall. Again, the negatives were very similar. They worried about false alarms, being jumped on if something went off when it wasn't supposed to, privacy and monitoring, the technical skills that were needed, the costs that might be associated, and again, a loss of human contact that these things might engender. So overall, we found, or they found, that older people were very receptive to these and keen to learn about these new technologies, but they had some concerns. They were concerned about data security and privacy, things like hacking even, that data might be hacked and maybe even sold on to other people. They worried about Big Brother overlooking what they were doing and wanted to balance the feeling safe, particularly as they got more frail with a feeling of being constantly surveilled. They wanted to know that these things were acceptable and affordable, that they would be readily maintained, and that they shouldn't replace a sense of a human touch, that ageing in place should not mean social isolation. Jackie Street said that Teresa was leading this project when she retired from work and was planning to develop an ARC linkage project or an application to the Wicking Trust. She said her work lives on and a paper based on this will be submitted early 2022. And she privately conveyed that wanting to honour Teresa's memory was really what was keeping her working on it at this point in time. Not surprisingly, a number of policy recommendations, which again really do reflect Teresa's interests and passions. First of all, if you're going to make these things, make sure that they actually do work and do solve a problem that people actually have rather than the problems we think they might have. You need to consult with them. Maybe allow them to try before you buy through demonstration sites, and above all, make sure that they have appropriate advice on what this will mean for them, what the implications for security, safety and privacy might be. The next project that I'm going to look at exemplifies all of the areas that I mentioned earlier: unheard populations, health policy and systems, clinical practice, and teaching and mentoring within public health. It's part of an NH and MRC partnership grant entitled Investigating the Inclusion of Vulnerable Populations in Advanced Care Planning, Developing Complex and Sensitive Public Policy. This project was founded on a pilot study funded by the Northern Communities Health Foundation, led by Teresa, and looking at the views of those working with vulnerable communities regarding advanced care planning, planning for the end of life, planning for that time when you may no longer be able to direct your care. What would you want? Who would you want to speak for you? Following that project, Teresa conceptualised this project from the ground up, including the need to combine the perspectives of patients, carers, health professionals and policymakers. She brought to bear the keen focus on vulnerable populations and the voices of those that are seldom heard. In this study, that included culturally and linguistically diverse communities such as Vietnamese, Bhutanese and Italian, those with chronic diseases diagnosed with cancer, COPD and dementia, and Aboriginal and Torres Strait Islander peoples. She insisted that the project be as much as learning about how to ask the right questions of the right people in the right way and at the right time, as it was about addressing specific questions about complex public health policy. She brought together a very large cohort of partner organisations, 10 that are listed here, and co-led a team of researchers that included myself, Ian Olver, Terry Dunbar, Greg Crawford, Bernadette Richards, Tanya Zivkovic and Debbie Faulkner, with Michelle McKinnon from SA Health. A very diverse set of researchers with very diverse different skills to bear on this complex policy problem. She brought together a budget, bringing these contributions together. She also inducted, supervised, mentored and collaborated with Catherine Hodgetts, who was employed as project officer and subsequently as project manager on the successful grant. And I'm going to talk about a particular project within this. It's a huge project, and this is just one of 4 different phases that she was most involved in. I'd like to acknowledge that in these presentations I'm drawing on her work, but thematic analysis by Catherine, clinical support and advice by Gregory Crawford, and statistical analysis by Hugh Hunkin. So this was initiated in recognition that advanced care planning has been recommended as a key means of ensuring high quality, patient-centred end-of-life and care. And SA legislation was introduced in 2013-14 to promote the completion of advanced care directives by every South Australian, not just those facing illness and chronic end-of-life. The aims of this study was to explore the prevalence of advanced care planning conversations and documentation in the acute care hospital setting, and to look at the agreement between what was recorded and what the patients actually said when we asked them about it. The data were collected over 2 weekends within 2 public suburban hospitals. The response rate of potential participants after relevant exclusions was 70%, and complete data sets, case notes and patient survey were collected from 172 patients. But this was a huge organisational feat, and I want to just zoom in on what it took to actually do it. On 2 consecutive weekends, 1 hospital per weekend, Teresa organised for trained nurse researchers to audit case notes of every hospital inpatient, excluding maternity, paediatrics, ICU and emergency, and for members of the research team to administer a survey with every patient. This process involved her developing a case note audit tool to identify patients with chronic disease who would benefit from a palliative care approach, securing ethical and governance approval, and that's no small mean feat when you're working in hospitals. Developing a patient survey, developing data collection and storage methods, liaising with nurse unit managers to seek their on-ground support for the audit process, providing a whole day of training to 4 nurse researchers to seek patient consent and audit the case notes, developing a practical process, which was such a logistical nightmare, for audit days through which researchers could stay in touch, data could be collected and stored. There were methods of inclusion for people of non-English speaking backgrounds. We had 10 translated materials in the top 10 non-English speaking languages, ensuring access to the hospital wards could all be seamlessly managed. And here, in the midst of all that, Teresa still took time to sneak a chocolate bar to Catherine Hodgetts, who as project manager was trying to herd cats and keep us all on track. Teresa never lost sight of the individual. She never lost sight of those in her team and of the people within community. So, this is what we found, and I encourage you to look at the people with chronic conditions, as that's what I mostly focus on. There were roughly equal numbers of males and females within the sample, but for those without a chronic condition, there were 40% below 55, but only 12% of those with a chronic disease were below 55. There were few Aboriginal and non-English speaking people, and crucially, you can see that only 15 or 9% of those with chronic conditions had not visited the hospital at least once in the previous year, and more than half had been there more than 2 times. In the case note audit, we were particularly interested in evidence of conversations about advanced care planning. One of these was through a 7-step pathway, which you see here. It's an integrated care plan written for and by clinicians, designed to organise and improve patients' end-of-life care through use of structured documentation. So that's for and by clinicians. But we were also interested in those for and by patients. This is the South Australian Advanced Care Directive, or the first page of the form. It's part of the Department of Health initiatives from the legislation to promote completion of advanced care directives for all South Australians. We were interested in what this would look like. And what we found was that 145 patients had one or more chronic diseases. Of these, 6 had evidence that a patient had an advanced care directive, and only 3 of those could be found in their case notes. 65 people, however, had a completed 7-step pathway, and 52 of these limited interventions. 17 patients had some evidence of discussions where they'd named or talked about somebody who would make decisions for them when they weren't able to make their own, but only 11 of them actually had the name of those people in their notes. And when we compared what patients told us of what they thought had happened with what was in their notes, we found very poor agreement in relation to having advanced care directive or not. Few of them believed that they had completed an advanced care directive. Slightly more thought that they had discussed end-of-life care, but still not many, less than a third. Agreement relating to discussion of end-of-life care was better, but still only modest, and this probably reflects the situation that we found where advanced care directives are recorded or filed in places that aren't particularly useful when you're in hospital. They're at home or with the family or with lawyers. Or that people think that they've completed these documents, but they've actually done their will or a power of attorney. Let's look at what they told us in a little bit more detail through the qualitative data provided in the survey. We asked, why do you think some people might complete an advanced care directive? And some said that they wanted to state what they wanted before they can't do it themselves, so they'd already have those decisions in place when they couldn't make them. Others talked about the importance of ensuring that they would be treated the way they wanted and that the right person would talk for them. Others wanted to know that their wishes directed care, not the wishes of someone else, so that things they wanted were in place and no one else could decide for you. When we asked why some people might complete an ACD, they talked about things like quality of life, of not wanting to live with poor quality of life. So most of the time they wanted to limit interventions that would prolong their life without quality of life. They didn't want to be a vegetable. They also didn't want to burden family, their children, with that, thinking that was not fair. And also to stop disputes if family don't get on, which of course never happens in such emotionally laden times. Some thought it was important when you were very old, at your final stages, all the people that were getting elderly, which of course is never us. And others thought it was important if you were alone, if you had no one who was there to care for you. And we know that the number of those living in single resident housing is increasing over time. But when we said, well, why don't you have an ACD? They said things like, well, I didn't know about them until you mentioned them. I thought power of attorney would cover it. I didn't know they'd existed. Others thought that it was something they would do later. We don't need one right now. Other things take priority. And others thought that they didn't need it just yet. They'd never been this sick before. Others talked about lack of time and thinking it wasn't important. They advised it to do it, but we just never got around it. And others saw it at the bottom of a big pile of other paperwork that they encountered in the face of hospital admission and chronic disease. Some talked about how complicated. It's too blooming complicated. It's invasive. It was affronting and confronting. We're not doing it right now. And finally, others thought that they didn't need it because their family would know what they wanted. No need to tell anyone else. They know. It's okay. They know. So to summarise, we found a very low prevalence of advanced care directives in hospital notes and only slightly recall of conversations higher. This was despite overall positive perceptions about these things. Most people tend to think they are a good idea. I'm just going to do a quick hands. Just wave at me if you've completed your advanced care directive. Okay, that's about average. Not many. Patients with chronic disease had more knowledge about this, but it was still low. Approximately 1/3 recalled discussions, and fewer had appointed someone to make the decisions, and fewer again had an advanced care directive in their notes. And this may be explained by the qualitative findings that if it's for anyone, it's for people at the end of their life. That their family will know what, and do what they want, and that talking about that is enough. I want to go very quickly through this second study which has been published. This is the first of many that will see Teresa's name on them. In South Australia, advanced care directives intersect in the clinical setting with that 7-step pathway. Actually, before I do that, I'm going to go back because I want to share some words from our team member, Debbie Faulkner. She said that knowing Teresa as a team member on this advanced care planning project and all the prior planning has been a wonderful experience. Teresa was always cheery and had a smile no matter what. She was a wonderful soul, so easy to get on with, so welcoming. My life has been blessed by knowing her, and I will miss her, both as a team member and colleague, but I'll also miss running into her at the Adelaide Film Festival. So as part of this acute care setting that was led by Teresa, she also led 7 focus groups over those 2 hospitals with a total of 74 participants across the diversity of clinicians that come into contact with people at the end of their life. The focus groups were analysed thematically, underpinned by a critical realist framework. And again, I'd like to acknowledge and thank Catherine and Gregory in particular for their work, continuing the work that Teresa started and building on that. What we found is that 2 major themes, one comparing the relative value of these 2 documents and the other attending to the complexity of integrating these 2 very different documents that are supposed to guide clinical practice in the hospital setting. We found that healthcare professionals consistently conflated these 2 documents, seeing them as both examples of an advanced care plan. But advanced care plans were primarily valued as promoting patient autonomy and supporting quality of care, whereas the 7-step pathway was understood to promote clear communication between treating clinicians. A clear contrast between their understandings about the values of these was in terms of the tensions that could arise when trying to ensure that decisions made in that context reflected both a patient's ongoing preferences and met the requirements of informed consent. On one hand, decisions recorded in an advanced care directive were understood to be genuine, to reflect a measured process of thinking about it and thinking about your own preferences. But on the other hand, they indicated that completion of the 7-step pathway on admission more fully supported informed decision-making because that reflected the particular ramifications of treatment in the light of the patient's current health status, which couldn't be fully predicted or understood in advance. Advanced care directives and 7-step pathway forms were respectively understood as static versus dynamic, as there was concern that the advanced care directives might be completed too far in advance. They were static. For example, without ongoing revision, in the light of changing circumstances, it was argued that the advanced care directives would be potentially rendered redundant and worthless documents that aren't really about what you want. However, the thorough integration of the 7-step and the Eliott form into hospital clinical practice was argued to be its strongest advantage over advanced care directives, and I think you can see that by the different prevalence of those in the hospital audit that we looked at. 7-step pathway documentation is routinely completed by clinicians as a matter of priority within 24 hours of admission. But nonetheless, they recognised the moral and legal weight of the advanced care directive, which reflected the patients written by the patient. Others were confused about or weren't sure about which would take precedent and suggested that whichever was done most recently was the one that should direct clinical care. They agreed that the clarity engendered by writing the 7-step plan can stop it from falling apart in the middle of the night. Sorry, I'm going to go back. Sorry. Rewind, jump to paragraph. They also indicated that the very principles underpinning the 7-step pathway, which was patient autonomy and consent, as well as clarity and transparency between treating clinicians, were potentially undermined in a system where the 7-step forms were expected as a matter of course. There was pressure to complete it, to have a conversation with patients when perhaps they weren't ready or they were unwilling to have that conversation. And the oncologists expressed that they got constant hassles that you need to fill in this form so that they would know what to do. They agreed that the clarity engendered by writing a 7-step plan can stop it from falling apart at midnight. But some indicated that they required particular professional skills that not everybody had. And they also considered that the requirements to ensure transparency of clinical plans at the end of life might mean that it became the only way in which limitations to care or conservative measures were perceived to be legitimate. Without the 7-step pathway, there was no way to stop aggressive treatment or interventions that were going to be just prolonging life without prolonging quality of life. And this would also undercut the perceived legitimacy of the patient-directed advanced care planning. So overall, the conclusion was that the advanced care directives are potentially valuable means of promoting patient autonomy, but they're poorly integrated and rarely completed. The 7-step was well integrated and provided clarity about clinicians' roles and responsibilities, but they were unsure about which they should follow if both were present. And the routinisation of the 7-step meant that it was understood as the only way to determine patient wishes and undercut the perceived authority of the advanced care directives, undermining patients' choices not to participate, perhaps, in end-of-life discussions. And in the midst of all this, Teresa was still teaching, supervising, and mentoring others. She mentored third-year public health students, Diana Sabadin and Sally Wong, summer vacation scholars Sarah Gluckel and Sean Cridland. Sean went on to do his honours, getting a first class with public health, and Masters Public Health students Orielua Fanoiki, and she also provided informal support for Afua Addo, connecting her in with residential aged care facilities to conduct her study. She also provided extensive mentoring for junior academic Catherine Hodges, and I want to share Catherine's words here. Teresa was the real deal as an academic. She was not about self-aggrandising, CV swelling, or epitaph writing. She was there because she knew her education and position meant she had a responsibility to work towards improving health outcomes for people whose health status, ability, or cultural background rendered them vulnerable. Her quiet, persistent commitment to this endeavour had made her an important role model for Catherine. She was deeply intelligent, deeply curious, deeply hardworking, and deeply generous. As a junior academic, I watched in admiration as Teresa drove projects with warmth, insight, and genuine curiosity. When Teresa contributed in a meeting, everyone listened, as they know her offering will be insightful, strategic, informed, and compassionate. She looks for opportunities to include upskill support and celebrate those around her, whilst being incredibly modest herself. Catherine says, My work has been significantly improved by her generous feedback, her openness to discussion, and willingness to share her skills. My working life at university has been enhanced by her wisdom, humour, and sparkle. I think we can all say that. Teresa is a leader in the truest sense, through living, teaching, and advocating values of inclusion, justice, and care. In addition to all this, Teresa also brought together the Dementia Working Group through her connection with the Nightingale nurses, who connected her with dementia advocate Ian Gladstone, who went on to chair that. She forged a connection with the dementia support group, Dementia Down Under, and invited its convener to join the working group. They were a close and enthusiastic bunch, meeting many times, including coming together for a Christmas lunch. The warm feeling amongst the group was entirely down to Teresa's ability to build and maintain connection with genuine care. And to the COPD working group, she brought warmth and care. On her invitation, the group came to include a range of important perspectives, from patients and carers to nurses, physios, and a psychologist. They also had a Christmas celebration, meeting many times. These are my words. I know that I'm not the only one to have those moments of unbelievable sadness, when I would want to turn to share a thought, a laugh, a whinge, to seek Teresa's calm, unfailing good humour, tempering a depth of insightful knowledge and compassionate wisdom. We are blessed to have our memories of the amazing woman, teacher, researcher, mentor, friend, and colleague that Teresa was. We miss her. Thank you, Teresa.
Oh, you got a tail. Yeah, there we go. I don't know if there'll be any questions. There might be, or comments from anybody who would like to change the mood a little bit. Anybody, any questions or comments from anybody?
There's so much more. Watch the space, because the project was weighted towards the end, so we could bring all those perspectives together. It was really important for Teresa that we didn't do the care silos.
Yeah.
We were able to break that down and bring it together. So it's really now that we're starting to see these publications come out.
Len.
Just a comment on the fantastic legacy of Teresa's work, and just as she worked across the school to bring us together, she worked across all the disciplines to ensure that we aren't in care silos as professionals in our working lives, but that others aren't. And so to the benefit for all of us, I would never apply for doctor's arms care directly if I had, sat and listened to her work. So I think that legacy is so important for us all to think about.
Don't sit in our little silos. That's right. Any other comments or questions? Okay, thank you very much, Jacqueline. That was very difficult. Okay, our last but not least presentation today is from Scott Hanson-Easy. I'll just try and get out of this first, so that Scott can find it. Now, Dr. Scott Hanson-Easy is a researcher and lecturer with a cross-cutting interest in critical health communication and how individuals and diverse communities make sense of and respond to health risks associated with climate change and natural hazards such as heat waves. He works in a cross-disciplinary academic environment and publishes broadly with colleagues in many disciplinary fields.
Most recently, Scott's research focuses on how communication efforts could better address cultural, economic, social, structural and discursive factors operating in different settings. And Scott is also the program coordinator for the postgraduate coursework degree of the Master in Public Health. So I'll hand over to Scott.
Thanks.
Your presentation.
I must confide, it's fairly tricky to come after that talk, and whilst Teresa's all in our minds at the moment, and
Where is the presentation, Scott?
it's the one called SPH Symposium, which really narrows it down. Well labelled. But I guess the only thing that comforts me is that if Teresa was here, she might actually get something out of the polemic I'm going to be giving. I'd hope. I'd be honoured if she did. But, thank you. Yeah. Sorry, I'll just navigate this. How do I control the little scrolly thing?
Use the down arrows.
The down arrows, yeah. Okay. Yeah, that controls the big one, isn't it? I want to control the little one. It goes to the next page, I think. I just want to scroll down here. I can't do that. That's right. Okay. You might remember this last year, but on the 4th of July, in a North Melbourne Housing Commission high-rise apartment building, the health authorities in Victoria had a hard lockdown of about 3,000 residents, many of whom were from a culturally and linguistically diverse background. They received no advanced notice or explanation of why the apartments were being shut down. They were confronted by police that surrounded the buildings and health workers in PPE. A temporary fence was erected around the building, and this was actually a secure exercise yard that gave residents a sense they were being imprisoned, though. An urgent care clinic field hospital was ostensibly set up, and that was perceived as a concentration camp by many of the people who had gone through war and persecution in their home countries. The pictures of this urgent care clinic were disseminated through many of the residents' kind of phones in the apartment buildings, and many of them interpreted the cement floors and the plastic fold-up chairs as very similar to detention centres that they had experienced in their home countries. The Deborah Glass, the Victorian Ombudsman, in her report, an investigation into the lockdown, said that documents relating to the lockdown asserted there were security concerns, suggested the towers were a hotbed of criminality and non-compliance. But the evidence was the vast majority were law-abiding people just like other Australians. It is unimaginable that such stereotypical assumptions leading to the theatre of policing that followed would have accompanied the response to an outbreak of COVID-19 in a luxury apartment block. What we see here is a palpable failure of health communication and policy, I would suggest. The residents of that building were often left to devise their own interpretation of what was going on around them. Many of them had English as a second language. Many of them were elderly. A lot of them had pre-existing health problems. And they felt they weren't and they weren't actually engaged or given appropriate information about what was happening to curtail their freedom. One man, who is the father of this, Libio Hassan, heard about the concentration camp / field hospital and decided that he wouldn't have treatment. And he had COVID and he had asthma as well. Over the weeks of the lockdown, his health deteriorated and he became racked with COVID-19. When the lockdown finished, he was eventually convinced to go to a hospital and to get treatment. He was at the hospital for 4 hours and he eventually left because he felt like nurses and doctors weren't listening to him and weren't taking his concerns seriously. He went back home, his condition got worse. He's eventually convinced to go to another hospital, a private hospital that wasn't run by the government, and he felt safer there. He was admitted to that hospital. 6 weeks later, he returned home and died within 2 hours. His death could have been avoided with proper health communication and policy that actually took into consideration the rights and the communication needs of these residents. So just wanted to touch briefly on health communication and promotion, what it's good for, and a lame joke, just to slightly lighten the mood. So many of the health measures recommended and enforced by governments around health and communication around COVID are really about changing behaviour. So changing behaviour to wear a mask, from not wearing a mask to getting vaccinated, obviously, that's very salient at the moment, to staying in lockdown or staying in your house if you have COVID. So health promotion really is about giving people choices to act in their best interest in terms of their health. So it's about informing or empowering communities to take informed action to protect their health and to act in the benefit of their community as well. So in many ways, COVID is the ultimate kind of case study in that way. We see health promotion, health communication, trying to get people to think about vaccinations, to alleviate fear, anxiety, and to accept the idea that maybe, not going to work or actually losing your job is in the best interest of health of the community. So after 2 years, many people have lost their jobs, and the idea that that locking down society or locking down communities and putting in restrictions is actually worth all that. So health promotion has a big role to play in justifying those policies. So I just want to go now to the to vaccination rates, because, as we know, vaccination in Indigenous communities is particularly problematic, and we see vaccination rates in comparison to white people compared to Indigenous people, especially in WA, South Australia and Northern Territory and Queensland, as being particularly low. And this has a lot of people concerned, and it is going to be very difficult to stop the virus in these communities once it gets in, which it has in some already. So kind of encouraging change and getting people to consider vaccination, it really is a race. So I've been doing some work with Wellbeing SA, and they're particularly concerned about vaccination rates in some of the LGAs in South Australia, and we can see that Salisbury and Playford in particular have much lower vaccination rates, second vax, compared to places like Burnside and other areas that might have a higher demographic. So while the kind of Australian immunisation register doesn't really capture ethnicity, we can deduce from these sorts of statistics that many of some of these kind of LGAs have much larger culturally and linguistically diverse communities and Indigenous communities as well. And we see the Australian kind of vaccination by state. We see that there are patches that are particularly concerning in northern Queensland, parts of Northern Territory and Western Australia. So what's kind of going on here, and with vaccination uptake, and it's kind of multifactorial and quite complex. So just very briefly, and because I can't see my notes, that is particularly problematic. So I'll just have to remember them, and at my age that's very difficult. So a couple of things. Access to vaccination hasn't been all that great. People aren't being able to get to clinics. Clinics aren't where they work, especially for some cold and low SES communities. Actually taking time off work is not really possible for them. Actual numbers of vaccines, especially in the early days, weren't enough. People weren't able to get vaccinated because there just wasn't enough doses. And we're also seeing that there's a correlation between states that have had very extended lockdowns, or cities that have had very extended lockdowns like Melbourne and Sydney now. Their vaccination rates are much higher than, say, South Australia's and states that haven't had such long lockdowns. But we're also seeing, and I think I can confidently say that vaccination uptake is also due to some fairly poor health communication from government, especially to communities who are not always at the centre of health policy and can often feel disenfranchised and marginalised in society. So with communities that don't feel part of the social fabric, in circumstances like these, when government's telling them to get vaccinated, they often and understandably don't really respond to messages like that very well, which is completely understandable. Especially when you think about what happened in Melbourne and in parts of Western Sydney, where the race card is pulled out to justify why people aren't getting vaccinated or aren't actually complying with social distancing and so forth. So how do we make sense of all this? My argument would be that traditional health communication has failed, quite staggeringly so, and that we need to take another perspective and maybe a critical interpretive perspective on how we can do this better and how we can start developing relationships with communities. So the critical and interpretive health communication theory provides kind of some really kind of interesting insights into what's happening and how we could actually do better in the future and now even. So it is critical of mainstream status quo health communication, which relies on basically the social psychological idea of the rational being and a very cognitive entity where we provide people with information and they make the rational, considered choice to follow that information if it's justifiable in their minds. The problem with this is that it ignores context and it ignores culture. And when people make sense of risks or health measures that aren't particularly they're not particularly comfortable with, they use their own worldview or their own culture and their friends and to make sense of that risk and to respond in the way that they think is reasonable. The problem with mainstream health communication is it doesn't consider these things and it just blithely throws information out there expecting people to make a rational choice. And as you know, we're not very rational beings and we often make decisions based on emotions, history, and what's going on around us. Chime in if you don't agree with any of this. You could have a discussion about it, or not. So I guess this is really comes down to, well, some of the problems come down to the idea of trust. So health crises like these, especially in pandemics that we haven't had for 100 years, obviously give rise to lots of anxiety, uncertainty, confusion, which in turn challenges the trust in the communicator, the government, health services. So they also illuminate kind of fissures in society. And you can see with the kind of different or disparate groups coming out onto the streets to protest against vaccination, mandatory vaccination, and so forth. So we have kind of left-leaning, green kind of anarchists kind of walking alongside right-wing nationalists. But they come together because they believe their freedoms are being limited. So what brings them together is a lack of trust and a lack of, well, this is my view, a lack of feeling like they're part of society. And for many called Indigenous communities, they feel the same way. They will respond in the same way, but they can feel the same way. So that is undermining some of the trust in vaccine safety that is being communicated by government, by the need for vaccines, for vaccination, and is really undermining the kind of relationship the government needs with communities right now. So trust is not something that can be kind of developed overnight. It's not something that can be kind of found, you know, in communities after a meeting. It's something that actually takes a long time to develop. And for many called Indigenous communities, I'd posit that that trust has been eroded for many, many years. And we're seeing this kind of trust or lack of trust play out in people's motivation to get vaccinated. We're also seeing trust being eroded by the infodemic, which the UN has coined by infodemic in terms of it's characterising the amount of information that's out there around COVID and vaccinations, and it's very difficult for people to actually differentiate between good information from government that is credible and fake news and misinformation and disinformation. So, and when there's so much information, trust is eroded. And it's very hard for communities to find credible information that they can base their behaviours on. We also know that much of the health communication interventions that have been put out there have a reading level of 8 or above. And some researchers just recently looked into that, and it's based on the gobbledygook scale of interpretability, and it ranges from 5 to 30, when most, the average reading kind of level is 8. A lot of this communication is above 8, and that's for mainstream society, let alone called and Indigenous communities that might have English as a second language. So the communication, the actual messages are above the literacy levels of most in society. So, okay, I can complain about all that stuff, but it's good to have some sort of remedy or idea of a remedy about how we might improve communication with communities about COVID or any other health issue for that matter. So I've been working in this space for about 8 years. I've run projects with called and refugee communities and made films. And I guess one of the things I've learned is that, and from the literature suggests that if you're going to start kind of promulgating or sharing information about health, communities themselves are the best people to work with. So a community-based approach that I've used is kind of blending expert views with community views around the issue, and to ensure that the information is actually surrounded or integrated with the lived experience of communities in their first language, which accounts for the contextual facets that they're living with every day. So it kind of eschews this idea that people in government buildings know more about communities than the communities themselves, and that they can intuit, I guess, what communities want to hear and when they want to hear it and how they want to hear it, through what channel. Which is quite, to be frank, kind of arrogant. And it's kind of undemocratic. If you're going to work with community and expect community to do some pretty hard things, like lock down or go into isolation, then you really have to sell this relationship that you have with community, and that this is a community level intervention that's going to be in the best interests of everybody. Governments rarely do that stuff. So the kind of top-down linear approach to health communication fails because it doesn't respect or respectfully engage with communities or bother to understand their priorities, their levels of health literacy, and the kind of ways they want to learn or come across information. For example, I was running a project 7 years ago or so, which was interested in how newly arrived refugee groups perceived or understood the health risks from heat waves, bushfires, storms and stuff. So I drive out to Narracourt and join a meeting of mainly Iraqi new arrivals on short-term visas. So I waltz into the room and there's 20 Iraqi men there, and I start to ask them questions about heat waves and storms and whether they're worried about them. And there's like a silence, and then they just say, "Can you tell us what the government's going to do about letting our families come and be with us?" And it kind of, what that moment kind of said to me was that this is not a priority issue for these people. And for me to come in and say, "What do you think about this other risk?" it's kind of just like nonsensical and kind of like really quite elitist. So the idea that I would come and say, "This is a really big health issue for you, potentially, and it supersedes your other concerns in life, and you've got to tell me stuff about how you perceive this as a risk," well, it's just kind of ethically quite dubious. So I guess we're starting with communities. It's about asking them, like, what is concerning you about your health? Is health concerning you? Are there other things in life that are concerning you more? Because before you start engaging on that level, you won't be able to actually develop anything of use. So I kind of use a community-based participatory research approach, and it's a collaborative approach to research, and it kind of tries to equitably involve all partners in the research process and recognises the unique strengths that each community or party brings, and begins with a research topic of importance to the community. And it combines knowledge and action for social change to improve community health and eliminate health disparities. So I guess this interactive approach that is commonly used these days in health can overcome some of those flaws around the top-down linear kind of communication approach that has failed so well, especially for minority communities, so miserably over the last 2 years. Right. Just as a way of an example, this is a film that I and the Australian Refugee Association made this year. We had a grant from the government, and we went to the Syrian community and the Hakka Burmese community and said, "What do you want to make a film about if you want to make a film about something that is concerning you in the way that you are living your lives in the Adelaide community?" And so it was completely open slather. The Australian Refugee Association, with my consultation, kind of went, trained a group of community members or leaders to go into their community and do research in their own community about what things were worrying them, what things were kind of impeding their integration into society. Interestingly, both Burmese and the Syrian community had selected, well, there are lots of things they worried about, but they selected driving and driving safety and licensing and things like that. Because that was a big problem for them, because it was so complex and so novel to them, the Australian system, that was endangering their, I guess, or risking their health in terms of crashes, but also financially quite risky, because they didn't understand the idea of licensing always, insurance and things like that. So they, along with Ara and myself, they wrote scripts which we turned into films. And I just thought I'd play a little bit of the film and then I'll take questions. Now I've got to go onto YouTube. So you could be exposed to an ad. Sorry. Or not.
Go to Shopify.com and easily create a powerful online store fully loaded with all the e-commerce features to run, manage, and grow your business.
لازم انت تعبيهم بحدا معه.
What's it doing?
موضوعنا اليوم عن الأمان والسواقة على الطريق. أهلا بك وسيم في سؤالك اليوم.
It should change. Hang on. Sorry. Isabel, help. So I can't control it.
Oh, yeah.
It's never in there.
It's done something.
Done something. I thought it would just come up.
That one? Oops. Oh, what have I done?
Isabel broke it.
Yeah,
It wasn't
broke
me.
it out.
I had nothing to do with it.
What is that? Something's going a bit weird with mine or something. Okay. There we go.
Thank you.
There. Let's go back a fraction.
أهلا وسهلا اليوم بكم في اسأل عمة. موضوعنا اليوم عن الأمان والسواقة على الطريق. نتمنى اليوم أنه تستفادوا من هالمعلومات اللي حنوفر لكم إياها. أهلا بك وسيم في سؤالك اليوم.
أهلا بيكي. سؤالي اليوم إنه اليوم أنا كثير فرحان وأخذت ال عملت الامتحان وأخذت ال بس عندي سؤال اللي هو إنه فيني أطلع أتدرب مع أي حدا؟
ألف مبروك أول شيء أكيد فيك وسيم خطوة كثير منيحة لك. أكيد فيك تطلع تتدرب بس كأمان إلك أكثر لازم من 5 ل 10 ساعات تطلع مع مدرب قانوني لأمان إلك وللآخرين بالشارع.
ولازم كمان تكون كتير حريص انك تكون تاخذ ثقه من نفسك بعد ما تاخذ هاي الساعات طبعا بالتدريب، ولازم تعمل هذا الشيء مع حدا من اقربائك او يعني صديقك موثوق فيه لما تطلع معه او بالتدريب. والاهم من هذا الشيء كلياته انه النقطه المهمه انه لازم هذا الشخص يكون معه اقل شيء سنتين شهاده السواقه.
لازم تتدرب 75 ساعة على الأقل لتعبي ساعاتك لأنه في 75 ساعة بقلب البوك لازم أنت تعبيهم بحدا معه فول لايسن 75 مع التدريب معه يعني ومع المدرب القانوني حتى تاخذ تجتاز المرحلة الأولى يعني لازم تعبي 75 ساعة.
وانت عندك معلومه ما بعرف اذا عندك هالمعلومه ولا لا. مكتب آرا عنده تواصل مع مدربين معتمدين يتكلموا لغات متعدده ومنها اللغه العربيه، فاذا حابب تتواصل مع مكتب آرا حتى تحصل على مدرب معتمد بامكانك انك تتصل فيهم وهم يوصلوك مع هذا المدرب.
اكيد حتستفيد منهم كثير وعندهم خبره بهذا الشيء.
ان شاء الله خطوه موفقه.
نتمنى لك الموفقيه يا وسيم واهلا وسهلا فيك. سمعتوا انه نجمة عملت حادث؟ حبيبتي ايه حرام وشافتني اليوم وقال بدها تسألك سؤال على الحادث. اهلا نجمة تفضل.
Okay, so all right, I'll take questions. Get that right.
You got any questions for Scott?
Lynn. Great, thanks.
I'm just thinking kind of about same but different or good different. But I think some of the challenges working with different called communities, the diversity, contrasting with Indigenous communities are profound. And perhaps you could comment on how to tackle some of those differences in developing communication strategies. Could we have common core that is then, I mean, consultation underpins all of it, but some of the differences perhaps in implementing this with remote communities, for example?
Yeah, that's a great question. Thanks.
Well, I know.
No, there's overlap. There's overlap. There are a couple of things that we can take from communicating with both groups, and they are very different, is that trust can't be engendered often through government spokespeople. It just can't. It just isn't. They just aren't seen as very trustworthy. So some research has shown that even though most people with a cold background in Western Sydney would comply with health measures, they would accept them more if they were actually filtered through community leaders. And that goes for Indigenous communities as well. So we just can't entrust important health messages to come from government directly to communities often. Where the differences are, especially with remote communities, and where we see in those statistics differences between white and Indigenous communities is distance and remoteness. But we're also seeing there was a void of communication about vaccinations with Indigenous communities early on, and into that void has gone a lot of information from right-wing kind of American groups, weirdly, and all sorts of other misinformation spread through Facebook and other social media. So, and that goes for coal communities as well. So I think there's some overlap in terms of trust and who communicates these messages, but we also need to see that kind of historical kind of background of these groups, and especially with Indigenous communities have experienced 220 years of oppression where government has been the enemy, then some other things need to be done to be persuasive around vaccination. There are different discourses for those groups as opposed to some core groups. There is a whole bunch of other differences around health, for one. So it's complex. There are. And every cold is a pretty unhelpful category. And there are cold is everyone who's not white, basically. It's a very difficult homogenous category and very unhelpful when kind of conceding or trying to make sense of communication to different groups, because every group will have different needs, and every Indigenous group will have potentially different needs as well.
Oh, you're taking the microphone.
I'm going to take it.
That's right, I'll use this. So that brings us to the end of our symposium. Thank you very much for everybody for coming today. That's terrific. Isabel, do you want to bring the... Scott, don't go too far, please. I'd just like to thank our speakers today for putting yourself through this. But it was fascinating. It just always goes to show the absolute breadth of research that we do in our school and how public health touches on so many areas of society and different groups. And so I'd like to thank you all. So that's Lynn, Jacqueline, Scott, Shona, Jackie's gone, and pardon? And Maha. Yes, Maha. There we are. So if you could come down, please, and grab a little goodie bag as a thank you for today. Thank you. Thank you very much to Pamela and to Phil, who had to leave, and to Teresa's family as well for coming today and helping share everything. Come, please just grab one. Yeah. Thank you. Yeah, just go for it. Thank you very much.
Jackie as well?
Yes, if you could. Yeah, that'd be great.
I reckon that's great.
You all right? So thank you very much for coming today, and hopefully we will see you again next year, and we will be able to fully open to the public instead of having the public on the online. We'll see what happens with COVID, I guess. So thanks very much and have a good afternoon. It's only 10 minutes.